طبعا انا اشكر الناس اللي جت بدري، عشان كده احنا هنبتدي في ميعادنا، مش عايزين يبقى عندنا ديلي ان شاء الله يا رب. دكتوره هبه راشد بقى مسؤوله معانا المدرسه المؤتمر، احنا مدين وقت كويس للسبيكرز، مفيش حد يعدي وقته، يعني ما دام واحد ليه وقت ينظم محاضرته على وقت. فطبعا انا يسعدني ان احنا نبتدي الفيفث سكول نيورو ماسكولار سكول اند كونفرنس السنه دي. We have the pleasure to have with us Professor Bjarne Ud, Professor of Neurology and specialized in neuromuscular disorders in Tampere University in Finland. And of course, this is not the first visit for Professor Ud. The first time was in 2015. Yes, then we came 4 times.
Okay, yes, and then COVID.
Yes, until the COVID. And then again, he is with us. Professor Ud, he's one of our teachers here at Ain Shams, and he encouraged us to have the whole body MRI muscles in Ain Shams University. And he put the protocol with us, and we published about 2 publications with him about MRI muscles in congenital muscular dystrophies. It's our pleasure that Dr. Ud will share with his experience with us. أنا هبتدي معاكم زي ما احنا متعودين كل سنة، هنبتدي بالشيت، وبعد إذنكم خلوها interaction، يعني اسألوا. This is the time for questions. السكول بتدينا ال opportunity to have questions. Anyone he can ask any question to his colleagues, to me, to the professors at any time. Okay? تحط لنا البرزنتيشن. طب وانا احركها من عندي؟ اخلي المايك للدكتور.
Okay, yeah. So should we wait until 9:30?
No. Okay. It's 9:30. No, the chair said it is not 9:30.
It's 9:29.
Yes.
Okay.
حاضر. اللي معانا بقى فكروني دكتورة. نيفين منين يا نيفين؟ اوكي ماستر يعني.
هو الدبلوم العام.
الدبلوم العام، اوكي. ماشي محدش جه غيرك، دكتورة هبة أول واحدة جت.
وفي منا كمان جت دلوقتي.
دي لسه داخلة. يلا. سو المعهد القومي للجهاز العصبي شال الأطفال سابقا، وهي دكتورة ندى دلوقتي ماستر وبيتحضر في المايتونيا. اما نشوف الأمر. مدرس انت مروه معانا؟ سبحان الله بتحلو كده. اتفضلي يا فندم. دكتوره منى. مدرس مساعد عين شمس. ها
دكتوره نهى، انا زميله في معهد القومي.
ازيك يا نهى؟
دكتور احمد
كوبري القبه العسكري، اهلا وسهلا.
محمد بدر كمان كوبري القبه العسكري.
تمام. ايه؟ فين؟ نسايم؟ فين نسايم دي؟ مدينة نصر، يعني تأمين صحي يعني. برايفت، اوكي. اسمك ايه؟ رنا؟ تمام يا حبيبتي.
مكاريوس، ساحل التعليم.
تمام. From where? صومال. أهلا وسهلا.
فاطمة. في أزهر ماستر.
منين؟ فاطمة؟ Maldives. Wow. We have a Maldives. الزهراء الجامعي. اه عندنا معانا كتروا قوي ما بقتش عارفاكم.
انا ما اعرفهمش.
لا كل شويه يشوفوني يقولوا لي بقى. تمام. اهلا وسهلا عندنا في القصر العيني. اهلا وسهلا. تعالي عرفي نفسك بقى.
انا معايا دكتور مدرس مساعد منه.
عارفاك يا مها ده اسمه ساعد.
ومها عندها توك النهارده برضه يا دكتور.
اوكي اوكي مها ايه؟
مها صبري.
مها صبري. مها صبري مش هنساكي خلاص. ومروه معانا ما شكلها اتغير قوي. لسه قال على البلطو. ما شفتكيش نايم ليه؟ شفتك نايم. I will start with the sheet first. Yes. Then you will start with the teaching of it. ماشي اوكي. طيب صباح الخير تاني. We will speak today in English because we have guests speaking in English. And the most important in our neuromuscular school is how to handle a patient. It is the most easy and most difficult job because all our patients looks like each other. Mostly they have quadriparesis or difficulty of walking, very few symptoms and many diseases. Until now, I'm working in this field for about 30 years and every patient is a new patient to me and still I see new syndromes and new diseases because this is a very big branch, many disorders and still they are discovering many diseases with many genes are newly discovered. So, how to approach a patient with a neuromuscular disorder? So, our disease is mostly hereditary or acquired. Usually, when you think about a neuromuscular patient, you think only about muscular dystrophy. This is completely wrong. And I will tell you a story during my talk about a big mistake some of our colleagues did with a patient because they think that any myopathy is Duchenne muscular dystrophy or any patient with weakness or quadriparesis, he has muscular dystrophy until proved otherwise. Although the inflammatory myopathy is more common than the muscular dystrophy. But usually because of big referrals of muscular dystrophies to our clinics, so we think that muscular dystrophy is more common than these acquired disorders. No, acquired disorders, the vitamin deficiency, the inflammatory, the endocrinal, these are treatable cases. So please usually think that you will have a treatable condition before thinking of genetic disorders. So these disorders could be acquired or could be hereditary, and it is the effect of any component of the lower motor neuron, anterior horn cell, root, peripheral nerve, neuromuscular junction, presynaptic or postsynaptic or muscle. Muscle is not belonging to the lower motor neuron, but these are the affected parts in our neuromuscular disorders. And you must remember another thing, that most of our diseases are systemic disorders, or they are multi-system disorders. The brain may be affected, the heart, the lungs, there may be affection of the eyes. Because if you have a patient with a neuromuscular disorders and he has heart block and you didn't diagnose, your patient may die and you don't know why my patient died. So, even the Duchenne now, even the Duchenne is considered a multi-system disorder because the brain is affected, the eye may be affected, the heart is affected. So many systems can be affected besides the muscle affection, okay? So, examples, the myotonic disorders, the congenital muscular dystrophy, Duchenne, metabolic disorders, and inflammatory myopathy. So, neuromuscular disorder is like any neurological disorder. So, if you have a systematized thinking when you see the patient, where is the lesion and what is the lesion, you can reach almost the beginning of your provisional diagnosis. So, don't see the patient and say, oh, this is Duchenne. Even if he is Duchenne, this is completely wrong. You must think systematically. So, where is the lesion? Where is the lesion? In the components of the lower motor neuron, the neuromuscular junction, or the muscle. Very easy. And what is the lesion? It will depend on the onset of the course. To know the pathology, you must search for the onset and the course of the disease. And usually we ask in neuromuscular disorders about the age of the started illness. And we must make a hard job in asking the mother and father and relatives when this started, especially if this started since birth. So if it is since birth, it is very important. If it has an onset, when? And if it has an onset late, it may be acquired. So it is very, for example, you will see many patients in presentations of your colleagues, is it a congenital myasthenic disorder or acquired myasthenic disorder? So it is very important to know the onset. No, he was born with ptosis. Mostly it is congenital. He was born with this delayed motor development since birth. Or at the age of 5 years, he started to have an illness. Very important. So, to ask about the onset and the course of the disease, and to ask about the age of onset, even dated since birth, and age of lost ambulation also is very important. For example, Duchenne and Becker. Usually, Duchenne, the loss of ambulation is below 12 years. This is very important. So, congenital muscular dystrophies, maybe they are not able to walk at all. SMA type 2 or type 1, they are never walked before. So we must ask about this. The course could be regressive, stationary, progressive, fluctuating, episodic. This question is very important. Many patients with myasthenic disorders, they have weakness, they have quadriparesis. If we didn't ask about is it fluctuating or not, is there sometimes the patient is good, sometimes is bad, if we didn't relate his illness to his effort, if he's at morning his eyes are open, then at the end of the day he has ptosis, we must search for this. And also the rate of progression is very important. I will tell you the story that made me very angry. And I will ask you, what is the diagnosis? This is a boy, 10 years old. He was never ill before. He has normal development, and no family history of any neuromuscular disorder. Then 6 months ago, he started to have weakness of both lower limbs, proximal more than distal. It was painless. Then the weakness progressed to affect the trunk. Then the weakness progressed to affect the upper limb proximally. Then the weakness progressed to affect the neck, and he started to have neck drop. Then the condition progressed to have bulbar symptoms. I asked about the onset. They said 5 months ago, and he's 10 years old. And he come to me, marked difficulty of walking. He is walking supported. And I asked about the rate of progression. All of this, usually, all of this in 5 months, yes. All of this in 5 months, yes. Proximal lower limbs, trunk, upper limbs, neck, and bulbar. And he started to have some respiratory distress. What's your diagnosis, Minna? What do you think? When you have a patient like this, come to your clinic. What is your diagnosis? Okay? يعني منا بدأت تفكر بطريقة سيستماتيك. ازيك يا بسمة؟ لابسة اسود ليه؟ ها؟ شياكة يعني؟ بقاء لله يا حبيبتي، بقاء لله. اتفضلي. لا المايك، أنا مدياك المايك.
I want to verify all the items of the history, onset, course, duration.
أنا قلتهم خلاص هم verified. بس أنت قلتي هسأل على حاجة مهمة.
Fluctuation regarding diurnal variation.
What is your differential diagnosis of this patient? Patient with rapid. وأنا على فكرة من كتر ما اتغصت من العيان ده واللي حصل له أنا جبت سؤال في الدكتوراه. أنا جبت سؤال دكتوراه السنة دي. I made this a question in the doctorate degree this year. What is your differential diagnosis of a rapid quadriparesis in a child with 10 years old with bulbar and the neck affection? First differential diagnosis. First differential diagnosis. Give me a diagnosis.
If there is diurnal variation,
yes,
I will put myasthenia gravis.
So Dr. Minna thought it could be a myasthenia gravis because of the weakness, because of the bulbar, because of the neck, and because of started respiratory. She will ask a very important question. Is it fluctuating? Is it related to effort? Is his as morning is good and at the night is bad? This is the first differential diagnosis.
Okay.
Second differential diagnosis.
Guillain-Barré syndrome.
Yes, polyradiculoneuropathy, but usually it is more rapid than this. More, but it could be. We must think about a neurogenic disorder. بلاش انت النهارده. Third differential diagnosis. مايك بسرعة يلا. يلا مش سامعة.
Inflammatory muscle disease.
Yes, inflammatory myopathy. It could be, and this was my first diagnosis because it took several months to affect the patient, the presence of bulbar, the presence of neck muscle and drop. The dropped neck syndrome has a good differential diagnosis. One of these is myasthenia, another one is myositis, another one is something if it is chronic like ALS and like this. So I thought about inflammatory myopathy number one, and usually inflammatory myopathy is not painful. Autoimmune inflammatory myopathy, and I thought about myasthenic disorder, and I thought about a neurogenic disorder like polyradiculoneuropathy. It could be like CIGP, not like Guillain-Barré syndrome. It could be a CIGP. Professor, what do you think about a patient like this?
Well, it's an unusual presentation. it's not the most common one. And I think the differential diagnosis now announced or suspected are well in line. There are some peculiar genetic disorders as well.
Yes, yes.
So we have TK2 gene defects, which can more or less do something like this. And
Which
especially the
disorder?
The TK2, it's a mitochondrial effect.
TK.
TK2.
TK2, a mitochondrial disorder.
Yeah, and we also have some peculiarly rapidly progressive laminopathies.
Okay.
With head drop,
Laminopathy. Okay. But in this age, 10 years old or
yeah,
very early?
usually they have a longer progress still. So,
Okay.
but some of them may develop quite rapidly.
Okay. So what made me angry is that child, he went to one of the biggest university hospitals in pediatrics and a pediatric neurology unit specialized in neuromuscular disorders. The diagnosis was Duchenne muscular dystrophy versus a Pompe disease. And they introduced the condition to their professor on call that this is either a dystrophic or a metabolic disorder, and they ordered for dry blood spot of the GEA enzyme and waiting the results that may take about 1 month in Egypt. And they was thinking about giving steroids or not, so they said no, we must have the result of the Pompe disease first, and then was thinking that later they will do a genetic diagnosis or a genetic testing. I was very, very angry because the respiration is started to be affected. So this is what I'm telling you about the rate of progression. It cannot be like this. Okay, the professor said very rare disorders like laminopathy or a mitochondrial disorder. It can be some metabolic disorder, but it can, what is common is we must think about the differential diagnosis you said. Then I had to call the professor and tell her all of this occurs in 5 months. And I returned, I asked for 2 things. They didn't do nerve conduction EMG. I asked for the lab, CK. Of course, they did the CK, it was very high. I asked for nerve conduction EMG. It had the manifestation of myositis. It had a resting activity and a myogenic EMG. Then I asked for 2 things, whole body muscle MRI, and I asked for antibodies for inflammatory myopathy. So we have now in Egypt the panel of autoantibodies for the inflammatory myopathy. And I returned to my colleague to tell her what happened. She was also very angry. Then the whole body muscle MRI, the stir Excel images, all was edema all over. The most evident edema I never see like this. All the muscle were edematous, inflamed. And what was the result? We have anti-HMGCR. He was positive anti-HMGCR antibody. So again, it is a necrotizing type, a necrotizing myopathy. And the response will not be good with steroids, and we must have either something like IVIG, immunoglobulins, intravenous immunoglobulin, or something like rituximab therapy. They were waiting. And when I returned the child to them, they have to put him in pediatric ICU because his oxygen was started to be down out of respiratory muscle affection. So this child was about to die because they were in a clinic. We have very, very crowded clinics, about 50 children at the same time crying. Then about this quadriparesis, 10 years boy So he must be Duchenne until proved otherwise. This boy was about to die. But of course, they started immediately the IVIG, and the patient was saved, and he started to improve within 3 to 6 months of time. So this is very important. I don't want you to learn by heart. I want you to see patients and to start why I'm saying that the rate of progression is very important. Why I was very happy from Menna when she thought about, what about this weakness? It may be fluctuating. You didn't ask about relation to effort. Also, some fluctuating weakness may be related to metabolic disorders or mitochondrial disorder. Mitochondrial disorder also may be related to effort. So you must think rapidly. But when you have this marked neck drop and respiratory, you must think to save your patients. And don't forget to do for him ECG and echocardiography. Maybe also he has associated carditis. Okay? So please, not all the boys with quadriparesis are Duchenne or muscular dystrophy. Think about more common condition that is treatable. أهلا وسهلا. تمام.
I would just have a
Yes.
comment that bulbar symptoms are quite unusual with this condition. But you have to consider also variations of, of disease types that you thought you knew already.
Bulbar symptom is not common in necrotizing myopathy.
No.
Anti-HMGCR
That,
was above 200.
Yes, yes, yes. I mean, the diagnosis is completely perfect.
Yeah.
And just for you to know that this disease, the HMG-CR, antibody positive immune-mediated necrotizing myopathy, was first understood to be caused by statin use. First identified in statin users, and just a few years ago, we have learned that it can sort of be presented also in children, which was previously in the beginning not known at all. So we have to, it's a good example of these peculiarities.
Okay. So this was a question in the doctoral degree of neurology Ain Shams this year, and I was very happy that most of the assistant lecturer answered the question very well and very good differential diagnosis. Okay, so this is our simple motor unit, anterior horn cell, root, peripheral nerve, dendrites and neuromuscular junction, and the muscle. The lower motor neuron is not including the neuromuscular junction or the muscle, but this image or cartoon will show you where is the lesion, how to think. Where is the lesion? We give some differential diagnosis like this. So it could be a disease of the anterior horn cell, but there is some characteristic of fasciculation, especially in the limbs and tongue. We must ask in history and search in examination. About the radicular affection, we must ask about radicular pains and search for stretch signs, brachial stretch, sciatic stretch, femoral stretch. About the peripheral nerves, we must search for usually a distal weakness, atrophy, motor or sensory affection or autonomic affection. And about the neuromuscular junction, we must ask, like the thinking of Minna, to ask about diurnal variation, a fluctuating weakness, a relation to effort. And for the muscle, of course, the muscle usually weakness, usually there is selectivity. It takes some heads of the muscle, and it can take one head and leave another head, or can take one part of a muscle, or can take a muscle and leave a muscle. And usually, don't forget, another disorder is the myotonia. You must ask about myotonia because it could be a distal weakness of hands, and we are thinking about a neurogenic or myogenic disorder, and we didn't ask or search for myotonia, then you discover that this is myotonia. There's also a proximal myotonic disorder, especially type 2. There is congenital myotonia. I think we will have in the school patients with myotonia? No? Okay. Family history. I was angry sometimes from Ain Shams department. Why usually you put family history before the history of present? No. We must ask about family history because usually our patients don't tell us there is a similar condition. And we do a lot of investigations. Then after 2 or 3 months, they tell you, okay, his sister has a similar condition. So when there is a similar condition, your thinking will go to many disorders, especially genetic disorders. So family history is important in Egypt and Arab countries, especially consanguinity, which is very common. It is very common, reaching up to 40% for any disease, similar condition. When you have a similar condition, for example, a boy and his sister, you will ask about the age of onset of disease and the severity of the disease. If he is Duchenne with a severe muscle weakness and his sister has a milder weakness, so she may be a carrier. This occurs usually in X-linked disorders. But if both the boy and the girl, his sister, have the same severity, so you can think about an autosomal recessive disorder like sarcoglycanopathy. So this is very important. When you have a similar condition, so we must ask about what is the age of onset, what is the sex, what is the clinical presentation, is it the same or not the same clinical presentation? For the mother, the history of abortions, stillbirth, death of relatives, what is the cause of death? His father died, why his father died? Severity of affection of family members to search for clinical carriers. Examination of family members. I remember my first case of facioscapulohumeral muscular dystrophy. She was a girl, about 12 years old, and they said, no family history. And she had a mild facial affection. She had upper limb affection, a distribution like that of facioscapulohumeral. And we were investigating why she has like this and so and so. And then at the time of the visiting relatives in the hospital, my professor told me, go and examine the family members. Then I found there were about 3 brothers and sisters affected, and the father himself was affected, and the uncle was affected, and her cousins were affected. So all the family has, so it was autosomal dominant FSHD. This was I will never forget this, and usually I ask, please, we do like this in the clinic, bring brothers and sisters, where is the father, where is the mother, and examine this, especially for autosomal dominant disorder. So, a mother of floppy infant with congenital myotonic dystrophy, she may have this myotonia. A mother or sister of Duchenne muscular dystrophy, we all do this now. We do screening for carriers. So the family pedigree, I ask all the residents and assistant lecturers, please draw a family pedigree in your sheet. Is it autosomal dominant, recessive, X-linked? We can think about a mitochondrial, sporadic. Sporadic could be acquired or also of a genetic nature. So, what is the presenting symptoms? As I told you, we have very little symptoms of many and many and many disorders. So one of these is delayed milestones of development. When I started my residency, I saw that the onset of Duchenne is first decade, I start to ask about 5 years old. But now, when we have many Duchenne, we know that the onset started since birth. And usually, most commonly, patients with Duchenne have delayed motor development, delayed speech development, delayed intellectual or cognitive development. We must ask about this because of congenital myopathies, congenital muscular dystrophies, and most of our disorders. So we must ask about the milestones of development. What about the weakness? What increased, what decreased, and what about the muscle bulk? Repeated falling, difficulty of walking, pains and tenderness, hypoesthesia and dysesthesia. This is usually our complaints or our presenting symptoms, and from every symptom of this, we search. Usually I ask myself another question: is there a lesion? For example, these years, many young generations come. I have fasciculation, I have ALS. Okay? I must consider this because in Egypt, we found in a small cohort that we have 50% of our patients are young generation. Below 30 years old, Jaradwa? Huh? We have below 50% of our patients below 25 years. So, and we have a famous football player. He has ALS in his 20s. So you must ask yourself, is there a lesion? So you have to examine him, and you have to do neurophysiology, nerve conduction EMG, and to reassure him that he has no this illness, or if he has so usually I ask, is there a lesion? But I consider organicity first. I consider organicity first before I think it could be a functional or a psychogenic disorder.
So, do you have genetic findings in these early onset ALS?
Yes, we started to find the SOD1 mutation. Yes, we have about, it is the most common until now,
Okay.
SOD1. We have about 5 families will be presented in Thursday, and I have another 3 or 4 families. But we didn't find C9orf, and we didn't find, we have
later.
only one family of C9orf, one family only. We have FOS, one. And I think the genetic mutations will be high in Egypt because of this is very early.
Yes, the early onsets should be
Yes.
genetic anyway.
Okay, so these are the presenting symptoms. We will analyze the weakness as we do in neurology. What about the anatomic distribution, the pattern of weakness? Is it focal wasting? Is there hypertrophy? Very important sign, especially in Duchenne muscular dystrophy, is the calf hypertrophy. And it could be present in other limb girdle or metabolic disorder, or even spinal muscular atrophy type 2 and 3. Some of them, they have calf pseudohypertrophy. Proximal versus distal, symmetric versus asymmetric. Some disorders, they have asymmetrical affection. Myopathies have weakness that is usually proximal more than distal, with some rare exceptions, of course. Increased fatigability. Please, when you have a neuromuscular sheet, don't forget to ask about myasthenic symptoms. And don't forget to ask about myotonic symptoms, because usually we forget about this disease. Myasthenic disorders and mitochondria, they can have increased fatigability. Metabolic disorders like Pompe, we found many patients with Pompe in our department. They have this increased fatigability and cramps with effort and exercise intolerance. Men are like this. No, it is not fatigability. It is exercise intolerance and cramps. Okay? If infant or child, parents, no developmental delay, floppiness, difficulty of walking, running, repeated falling, and skeletal deformity. When you have a skeletal deformity, This is very important because there may be a genetic background about this. Other important symptoms. When you are in the clinic and they come, they have difficulty of walking, so you think that this is weakness, and you find that it is a coordination, ataxia. So please, you must complete your sheet. You must search for coordination deficit, sensory symptoms. You must ask about convulsions, any epileptic phenomena. You must ask about other systems. Your patient may die, and you don't know why, what is the cause of death. Guillain-Barré may die out of autonomic neuropathy and arrhythmias, and you are caring about his weakness. No, his heart is more important than his weakness. His chest and respiration is more important than his weakness. So you must search for a cardiac, respiratory, endocrinal, metabolic, vision, hearing, mentality, dermatological. We have many inflammatory disorders with dermatological affection, skeletal or congenital anomalies. History of medications, of course, poisoning foods, exposure to insecticides. In Egypt, we have like this, and they came with ALS-like syndrome. In general examination, the vital signs is very important. So please, this patient with neuromuscular disorders is like any neurological disorder. Vital signs, skin lesions, lymph nodes, joints, endocrinal system, heart, chest, abdominal examination. Testing of the cranial nerves. What are the important cranial nerves for us? The optic nerve examination, extraocular muscle testing, palatal, pharyngeal muscles, laryngeal muscles, masticatory muscles, facial muscles, and tongue muscles. And you must search for tongue atrophy and fasciculations. Usually, I take the patient from above down. After I see the vital signs, especially the respiration and the heart, I take the patient, I tell my colleagues like this, from his hair to his nails, and I'm searching about these signs. You must remove clothes. How can you examine muscles and he's having the clothes? But because usually our patients are shy, so we must be in a private place. I remove of course, it must be to remove all and to have a gown. We don't have this in most of our clinics. So we can be in a private place, then cover the upper part and search thoroughly for the muscles, atrophy, fasciculations, any skin lesion. Then usually I do like this, I cover him and ask to unbear the lower extremities to search again for the weakness, the calf atrophy or hypertrophy, the fasciculations. You cannot examine while the patient have all of these clothes. So you must remove the clothes, atrophy, hypertrophy, calf, deltoid, pectoralis major, masseter, fasciculation, either spontaneous or provoked by tapping, by doing exercises, by cold. It could be a benign or pathological fasciculation. What is the difference? Yalla Marwa. What is the difference between benign fasciculation and a pathological fasciculation? Because many of young generation came to us in clinics, they said, I have fasciculation. Just a moment. يلا مارو.
I think fasciculations, pathological fasciculations are due to affection of anterior horn cells, but benign fasciculations...
Clinically. How can we differentiate between benign and pathological?
Pathological fasciculations are present at rest when the muscle...
both are present at rest. And both will complain. يلا ندى. لا خدي المايك بسرعة.
field rather than seen.
مايك.
الباثولوجيكال field rather than seen. الفسيولوجيكال
سين
قولي لها يا بسمة.
العكس يعني في واحدة
ايوه، ما هي
بنشوفها،
بسمة هتقول لك مين فيهم.
هي المفروض ان هي الباثولوجيكال بتبقى معاها associated symptom تانية بتبقى just fasciculation.
اوكي،
الباثولوجيكال
ايه الاسوشيتد سيمبتومز
ممكن
يعني؟
يبقى في weakness
weakness, atrophy.
او حاجة زي
ويكنس، اتروفي. اوكي، ندى كانت بتقول حاجه مهمه قوي بس هي لخبطت. which is more felt than seen.
الباثولوجيكال بتبقى فيلت اكتر منها سين، يعني البيشنت بيحس بالرف اكتر، لكن الباثولوجيكال هو ممكن
انت ايه رايك يا رضوى؟
ممكن تحرك
انا رايي
الحركة
العكس، انا رايي العكس. احنا واحنا رايحين الامتحان بنقول ايه؟ I have fasciculation. Okay, I'm examining, searching. Maybe I can find one. But the patient, you ask him, okay, occasionally I have one here. Then you are under him and you discover that all the limbs have fasciculation. So usually the pathological is better seen than felt. And the physiological is usually felt than seen. And again, there must be weakness, there must be atrophy. And usually there is an anxiety with those complaining of benign fasciculation, a lot of effort, hard work like this. What do you think about pathological and physiological? طيب، ندى خدت المايك مش عايزه تديه لحد زي كده بالظبط.
Yes.
Yes.
I mean, if you have additional features like atrophies or changes in your reflexes, of course, these are heavy indications of pathological. But in some cases, it can be quite difficult to know.
So we must complete investigations in some cases.
Yes. Anyway, so early changes in motor neuron defects may not actually be already causing atrophies or any major changes, and you have to be careful.
That's why I believe the patient, even if I'm clinically feel that he has no illness, I continue investigation. I do lab. I do a neurophysiological protocol. There is a special protocol for ALS or for motor neuron disease. I do like this. So I will not miss an early case of motor neuron disease. Okay? تمام. طيب, inspection of facial expression or the faces. Usually when the patient come to you, you must look for his face. Congenital myopathies, they have some myopathic facies, myotonia, facioscapulohumeral, this facial diplegia, some dysmorphic features in some metabolic disorders. This is, for me, is very important. High arched palate and high arched foot and the scoliosis and kyphoscoliosis usually are associated with a genetic disorders. So sometimes it may help, for example, in polyneuropathy, is it an autoimmune or hereditary type? When I found these skeletal deformities, I think it may be of a genetic origin or hereditary rather than acquired. And also, inspection of gait, go, sitting, standing, inspection for proximal muscles, Gower sign. This was very helpful to us in the clinic because the mother will come, there is a difficulty of walking of my child, he has muscular dystrophy, he has Duchenne. Then, usually we ask ourselves, is it a proximal weakness or not? So we do this Gower maneuver. We let the boy sleep on his back in the ground and ask him to stand. And we don't help him. Do what you want to do. Then he will turn and push the ground and push with the upper limbs and lower limbs and will push his trunk and pelvic region up, and then will climb of himself to stand. This is usual will denote this proximal weakness in the lower limbs, the pelvic girdle weakness, and the trunk muscle weakness. Sometimes some of these sometimes some of these patients, they came with CP, cerebral palsy, or hypoxic ischemic encephalopathy. And when we ask the boy to do, he stands, no proximal weakness. So this sign is non-specific to Duchenne or muscular dystrophy, but this sign is very important to know, is it a proximal weakness? So it could be mild, only affecting the lower limbs. Is it a proximal weakness? The boy has a proximal weakness or not. So we do this in the clinic. Usually you forget the neck muscles, although, as you see, this is very important for diagnosis. The respiratory muscles, intercostal or the diaphragm, this is very important. So search for neck muscles, trunk muscle, and paraspinal muscles, respiratory muscles, intercostal and diaphragm, weakness of upper limbs and lower limbs, and search for their distribution, individual muscle testing for selectivity, because muscle disease can affect the head of muscle and leave the other. For example, like myotonia dystrophica, it can affect the sternal head of sternocleidomastoid and leave the clavicular head. The opposite in Becker, it can affect the clavicular head and leave the sternal head. There is selectivity in muscle disease. And we use in the department is the manual muscle test, the grading British Medical Research Council. So 0 means no contraction, 1 flicker of contraction, 2 active movements with gravity eliminated, 3 active movements against gravity, 4 active movements against gravity and resistance but still weak, and 5 a normal power. This is for grading of muscles, very important. Passive joint movements for tone, contractures, and hyperlaxity. Some diseases like collagen 6, they have hyperlaxity of joints, palpation of muscle. You must palpate the muscle. You must feel the patient. It could be soft in hypotonia like spinal muscular atrophy, rubbery, the calf pseudohypertrophy. You must palpate, because the obese child, you may think that, or obese girl, you think that this is calf pseudohypertrophy. But if you have the feeling of rubbery, so this is a fibrocartilaginous effect. So you have to feel the muscle, especially calf pseudohypertrophy. In glycogen storage, they said it is firm. I didn't see this, but they said it is firm. Palpation of nerves enlarged in hereditary neuropathies, CIDP, refsums, leprosy, amyloidosis. Percussion of muscles, search for percussion myotonia, myedema, rippling diseases. We started to see Dr. Heba Rashid will have a very nice presentation about the spectrum of rippling muscle disease. This is the most famous and the classic and old classification of muscle disease. This is the Emery classification. And at that time, they put these major types of muscular dystrophy. This is for the distribution of muscle, because usually Duchenne and Becker started with the pelvic girdle muscles and take the muscles of anterior and posterior thigh, long, short, up to the knee. And the trunk muscle affects then the upper limbs. As I told you, the Becker can take also the neck muscles. For Emery Dreyfus, the classic one was X-linked. Now we have other autosomal disorders. So usually it started in the upper limbs with very early contraction. Both may affect the peroneal muscles. And then the limb girdle muscular dystrophy looks like the dystrophinopathies, but usually the short, they said the short is more short, and the neck muscles are not affected. Then we have the facioscapulohumeral Facial muscle affection, I will tell you, as a key in the diagnosis is very important. Then affection of scapular and humeral muscles, and may spread to affect the trunk and the peroneal muscles and the hamstrings. Then the oculopharyngeal affection of ocular, then affection of bulbar, then the upper limbs, and then it may progress to lower. This is a classic one and very important in classification. But now, as you know, after the genetic era, many classifications and the mode of inheritance different now. Some diseases they have added, like Emery-Dreyfus, more genes were discovered and different inheritance. Deep reflexes is usually lost in anterior horn cell disease, SMA, radiculopathies, distally in neuropathies, distal myopathies. In myopathies, reflexes are normal, decreased, or absent according to the stage and severity. But in myopathies, usually the ankle reflex is preserved until late in the disease. In myositis and myasthenia, the reflexes are normal. Sometimes in myasthenia, even brisk, except late in myositis, it can be diminished or absent. So we must search for myasthenia. If the patient has ocular, I ask the patient, fatigue, to look up for about 1 minute and see if the ptosis will occur or increase or not. Sometimes we do a bedside hydrophonium or prostigmine test. Coordination, please, and please don't forget ataxia. Sometimes we diagnose patients as myopathies and discover that he has a coordination deficit and he Friedreich's, for example. We have many mistakes like this. Sensations, very important to see the vibration sense, especially early in neuropathies. Trunk muscle stiffness for rigid spine. This is a very important sign, a rigid spine. And skeletal deformities, as I told you, the high arched palate, the high arched foot, the scoliosis, the kyphoscoliosis, very important. So, in neuromuscular disorders, when you are in the clinic, all the patient had quadriparesis. And you said myopathy. But there are keys of diagnosis, especially when you have atrophy or hypertrophy, calf pseudohypertrophy, localized or generalized. ده ايه ده؟ ايه؟ والله الوقت خلص؟ ما احنا عملنا شوية ديسكشن. الساعة كام؟ احنا سرحنا. طيب هناخد ربع ساعة. بس مين الراجل ده؟ اتخضيت بصراحة. طيب when we found fasciculation, when we found a rippling muscle disease, as I told you, hyperlaxity or contractures, ocular muscle, facial muscle, bulbar muscle, dropped neck syndrome has a differential diagnosis, axial muscle affection, rigid spine or spine deformity, pains and cramps like in metabolic disorders, myoglobinuria. We must ask about myoglobinuria in metabolic disorders. We must ask about myasthenic and myotonic symptoms. When you read more and more in neuromuscular disorders, you will do your list and increase your list in the diagnosis. For the when you have a patient with extraocular muscle affection, we must think about myasthenic disorder, thyroid disease, mitochondrial, myopathies like centronuclear, multicore disease, oculopharyngeal muscular dystrophy, inclusion body myositis late in the disease, or congenital ophthalmoplegia. So when you find extraocular muscles, you have some disorder to think about. When you have facial muscle, usually when we see a patient, we search for facial muscle affection. So with facial muscle affection, the FSHD, the facial-humeral muscular dystrophy, myasthenic disorders, congenital myopathies, mitochondrial disorder, Guillain-Barré syndrome, or CIDP. So facial affection is very important. These are the keys that can help you, اللي هو المفتاح, can help you in the diagnosis of the case. Okay? the bulbar dysfunction, myasthenic disorders. As the boy I told you about his story. Myasthenic disorder, thyroid disorder, oculopharyngeal muscular dystrophy, distal myopathy, polymyositis, and motor neuron disease, also ALS or SMA, they have bulbar affection. This is the myasthenic test you must do when the patient have ptosis or have a history of ptosis. So you must do fatigue of the extraocular muscles, and we ask the patient to look up for 1 minute, and then you can find that there is increased ptosis in one or both eyes, and this can be diagnostic of myasthenic disorder. Facioscapulohumeral, you must look for the facial muscle, ask him to close his eyes tightly. You still can see his eyelashes here. This is one of our patients with FSHD, and he has facial muscle affection. He has this marked asymmetry. You see the atrophy of humeral muscles here in comparison to this side, the pectoral muscle atrophy, and this when you look at the back. The other side, which was good, has this scapular winging, and this has a facioscapulohumeral. This is a clinical diagnosis, and we must diagnose because it has a different genetic testing than other disorders. And this is a hand. We have many, many patients of ALS these days. This is a hand of a classic ALS atrophy of small muscles of the head, first dorsal interosseous and other, and this is deformities usually found in ALS hand. This is the hyperlaxity, very important to search for when you have a patient with muscular dystrophy and has this hyperlaxity and has associated contractures, so this may have a collagen 6 disorder. This finger contractures, some disorders, they have this finger contraction, so you do the test by putting the hands together and see this contracture. And as I told you, a boy, weakness, you must search for calf pseudohypertrophy and palpate it. This is a boy, 5 years old with Duchenne muscular dystrophy. And this another Duchenne, but advanced. This boy was standing in the Demirdash clinic 2 weeks prior to loss of ambulation. He was about 10 and 30 years or 11 years old, and he was walking supported. He has marked peroneal affection and scapular winging and trunk muscle, lower limbs, upper limbs. He lost ambulation 2 weeks after this clinic. So usually you must diagnose the patients very early to give them the therapy. And this is one of our patients with Becker. He has this marked hypertrophy of calf and thigh muscles and also hypertrophy of the deltoid. This one of the patients with limb girdle muscular dystrophy, calpinopathy, they usually have this very early talipes, very early and very high talipes. They walk on tiptoes very early in the disease, and usually it is associated with calf atrophy and scapular winging. The presence of proximal affection of the pelvic girdle, the hamstring, with this very early talipes and the scapular winging, this is calpinopathy until proved otherwise. This is a boy with dysphalanopathy. Dysphalanopathy usually either proximal or distal, many types of the dysphalanopathy, but this boy, he had this calf muscle atrophy and very high CK and discovered to have dysphalanopathy. The myotonia, please don't forget the myotonia, because I misdiagnosed many patients of myotonia, and I started to learn to search for myotonia. This is the myotonic hand. Please ask him to clench his hands and open, or tapping of the tongue. Search for myotonia. This is myotonia dystrophica. Search for rigid spine syndrome, because it could be a sign of some diseases like congenital muscular dystrophies or even some autoimmune disorders. And we continue. This was the difficult part in the sheet. How to deal with the patient. How to think about your patient. When you have extraocular muscles, what is the differential diagnosis? When you have a facial, when you have a bulbar, when you have hyperlaxity. So you do a classic sheet, but you look for some, then what is the investigation done? Use all the tools you have. Use all the tools that help to diagnosis. We, in Egypt, we do serum CK and must be before EMG needle. We do the CBC, ESR, collagen battery, lactate and pyruvate and ratio. We do the ionized calcium, phosphorus, alkaline phosphatase. We do the thyroid and parathyroid and vitamin D. We found many patients with vitamin D deficiency or osteomyelitic myopathy. Acetylcholine receptors antibodies, muscle-specific antibodies for myasthenia. And also now we have in Egypt the autoimmune myositis panel, and we said the anti-HMGCR antibody, it helped in diagnosis of many autoimmune inflammatory. Please don't forget the heart, so you must do ECG and echo, respiratory, pulmonary function. The patient will die of this. You must do in every neuromuscular disorder. Okay, neurophysiology is your second hand. Your right hand is a clinical. Your left hand is a neurophysiology. And please, if you are a neuromuscular clinician, do it with yourself. Please, it will be better and better. The nerve conduction, the EMG, the decrement test or single fiber for myasthenia. Some patients, they have epileptic phenomena, we do EEG. This is, of course, we will have a very good, tomorrow, a very good workshop about neuropathies. And in this year, we will stress on protocols. When you have a patient with multifocal neuropathy, what we do? When we have a patient with suspected ALS, when we have a patient with suspected myopathies, what is the protocol? Not to do one muscle and one nerve and the patient will pay 1,000. This is not the aim. The aim is to diagnose the patient. So, of course, we have the insertional activity, spontaneous activity, motor units, interference, and we can diagnose a neurogenic or myogenic disorder. We can also have this fasciculation to diagnose anterior horn cell disorder, myotonia to diagnose myotonic disorders. Of course, the interference pattern will help. As I told you, when Professor Ud visited us in 2015, he put for us the protocol of whole body MRI muscles, and we put first here in Demirdash, then we put in Shams Specialized Hospital, then we upgraded the machines, and now we have very good radiologists helping us in the diagnosis of MRI. And also we have the ultrasonography of muscles and nerves. You will see about this today or tomorrow. We have a lecture. Brain imaging, of course, CT brain, MRI, MRA brain. طبعا ال MRI imaging help in inflammatory myopathy, myogenic and neurogenic disorders, will help in different muscular dystrophy and specific pattern to some types of muscular dystrophy. I will pass this now because I passed my time. And last is the two things. The genetics testing now, we do it before the biopsy or pathology. So we have some tests for Duchenne, for example, the MELPA dystrophin, for SMA, the MELPA for, or MLPA for SMN1 and SM2. Then we have some gene panels for congenital myopathies and limb-girdle muscular dystrophy. We can do whole exome, whole genome, or specific genetic testing like FSHD or myotonia, repeat expansion according to the disease. Muscle biopsy. I will stop here, but I was stressing today on the clinical presentation. how to deal with the patient. ازيك يا رنا؟ تمام؟ Okay, thank you so much. Any questions؟ أتمنى يا هبة ما نكونش عدينا الوقت. إحنا عدينا. ها؟ We did 5 hours only. Like so, we have to go for the next very, very exciting lecture. Professor Oud, I thank him so much. He took from his time and effort to be with us again in Egypt. And I appreciate this so much. Thank you. You are our teacher, and you will still be our teacher in spite of COVID-19.
Thank you so much for the invitation again. I'm happy to be here. I'm happy to see so many interested in neuromuscular diseases, which continue to cause problems for us, as you heard in the diagnostic field. But of course, we are waiting for more therapeutical options. But we first need to have the diagnosis. We need to have the difficult diagnostic systems in going and then
إنجي
know
تعالي يا إنجي في أماكن هنا يا جماعة تعالوا هنا.
what
Please
to
sit
do.
down, please. Okay. Professor Oud will talk about teitonopathies. What is the pathology of titin gene?
Yeah.
And of course, he's number 1 in the world in, yes, titin gene.
So as you heard, there are many, very many different phenotypes in neuromuscular diseases. And many of these different phenotypes can be caused by one single gene, the titin gene. And why is that? Well, it is because this is the biggest gene we have. It is about 50 times bigger than a normal gene. It is 8 times bigger than dystrophin gene, which was used to be called a big, very big gene. And that causes this enormous variation of outcomes because it has many different parts and domains with different functions. So if you have defects in different parts, you will have different clinical features and disease types. I don't go into all details, but we all carry a number of very rare missense variants in this gene. And that causes problems for the geneticist. What to do with these rare missense variants? Currently, we have knowledge of just a few of them. So most of these rare missense variants in titin gene are yet to be explored. And that will, of course, cause the different disease types yet to be discovered caused by titin will still expand. Moreover, in 1% of us, so in this group, some of you have truncating variants on one allele in this gene. So nonsense or frameshift variants, which are always pathogenic, but as you understand, when 1% of you have such heterozygous truncating variants, they cannot cause muscle disease in all of you. So they are usually, not without exceptions, but usually they do not cause disease in heterozygosity. But then, of course, if you have something on the other allele, then you will have a disease. There are very many different isoforms of that gene. So on the transcript RNA level and on the protein level. So we produce maybe hundreds of different types of titin we use, and we have no idea where they are, what is the differential function of these different isoforms. We know some differences between heart and skeletal muscles, that some exons are included or excluded. But that's not, it's just a minor understanding. We still need to explore much of that. So many of these isoforms are unknown, but we have some peculiarities. Do I have some pointer somewhere?
Yes. The upper one is a point.
Okay. Okay. Sorry. I will. Here. Okay. It just not came directly. So we have a peculiar area in this gene. So some 50 exons in the middle of the gene. These exons are mainly used in fetal life to develop muscles, but are not used after birth. So if you have a pathogenic mutation in those exons, it will have effect during fetal development, but if you survive after birth, these exons are not used. So the pathogenic mutation has no role. Peculiar. Anyway, the complex splicing pattern causes enormous problems for us to understand what the effect of specific variants in specific locations are. And we do not have full understanding. Anyway, here's just a short list of different phenotypes of tendinopathies, and as you can see, the expanding list is now due to the large use of exome sequencing, because previously only our lab could sequence the whole gene because of the size. Now all labs can sequence the whole gene. So we will have a look at some of these. We started with the tibial muscular dystrophy form, the dominant late onset distal myopathy, and associated with limb girdle R10 type, the childhood onset proximal in the homozygous form. We will have a look at that. We also understood the meaning of hereditary myopathy with early respiratory failure before the era of NGS sequencing. But now we have then a hugely expanding list of different congenital tendinopathies, a large spectrum either with cardiomyopathy or without. We have juvenile onset recessive distal tendinopathy. We'll have a look at that. Adult onset recessive rimmed vacuolar myopathy, childhood onset Emery-Dreifuss-like, and then a lot of new phenotypes. So we have non-progressive arthrogrypotic amyoplasia type, dominant intragenic deletions, biallelic truncating variants causing fetal lethality. We have also extraordinarily some dominant forms of truncating variants. And we have a number of recessive missense variants under investigation, and that will still expand. And these can or can be not be associated with cardiomyopathies, most of them. So here just some examples of what we know currently of phenotype-genotype correlations. So we started with the last exon, the 364th exon of the gene.
ممكن الصوت لو سمحتوا اللي عايز يتكلم هيطلع يتكلم بره بعد إذنكم.
And so dominant missense variants in this last exon, they cause the late onset tibial muscular dystrophy we first described already 30 years ago, before we knew it was titin. and it's the most common form of muscle disease in Finland and Estonia with the founder mutation, now also found in Estonia. And if you have that founder mutation in homozygosity or in compound heterozygosity with the truncating variant some elsewhere in the gene on the other allele, then you will have the early onset limb-girdle variant. If you have recessive variants in the second last or the last exon in homozygosity or in compound heterozygosity, again with the truncating variant, it will cause a juvenile onset recessive type of distal tendinopathy. And if you have, and you see the differences here on MRI. So this is the, yes, comes a bit, in the late onset distal tendinopathy, you mainly have anterior lower leg involvement and some hamstring involvement on the thigh, and very late, you see the age. If you have that homozygosity, these same areas are affected already at early age. We will have a closer look at that. And if you have this these recessive variants in the last exons, to have the juvenile onset recessive form of distal tendinopathy, you have more soleus involvement, also combined with anterior and peroneal involvement early on. So a bit similar to the dominant, but still at a different age and with the heavy soleus involvement. And these are more or less diagnostic patterns. And now something we don't understand yet, if we have that Finnish founder mutation or other dominant tibial muscular dystrophy mutations in the last exon, in compound heterozygosity with the recessive A-band missense variant, we have a totally different disease, adult onset recessive proximal myopathy with rimmed vacuoles, and then also the MRI pattern is different. We have heavy involvement of quads, nothing in the hamstrings and adductors, and again soleus without any anterior lesion. We don't understand why this happens, but that's the case. So this is the disease I started with. I saw my first patients 45 years ago, can I say that? Anyway, very mild and caused by the Finnish founder mutation, but we have now, of course, also other mutations. So the typical pattern, as I indicated already, the heavy anterior compartment involvement, the hamstrings, and so for some reason, gluteus minimus of the three gluteal muscles, the minimus is specifically affected. So we have other dominant variants in the last exon to cause the same phenotype. And one of these we thought was dominant, a Spanish-Portuguese variant, then turned out to be something else, because we had a family from Portugal with a young lady having a heavy distal weakness in the legs, and you can see the heavy involvement of soleus, peroneal, and anterior muscles without much in the calves. And she had this, we previously had seen in Spanish families, in homozygosity. And the parents were healthy at fairly large advanced age. So we then knew that this variant had to be recessive. And after that understanding, we then identified other similar families with this juvenile onset recessive type of distal tendinopathy. with either nonsense or frameshift variants in the second last or the last exon. So we have a bunch of families from Balkan region, and we also have new variants we have not reported yet to cause the same type of disease. So once again, to come back to the Finnish founder mutation causing that mild late onset distal tendinopathy at late age in the heterozygous state, and at the same age with the homozygosity, all muscles are gone practically. And that is, of course, not in the early stages. In the at the younger age, at the age of 25 in this case, you can see the first affections then heavily in the proximal muscles and just much less in the distal parts. And now the new issue that we have found this same mutation in the Balkan region in other countries, not only Finland. So this is an Estonian boy with that Finnish founder mutation in compound heterozygosity with another truncating splice variant in the gene. So do we know anything about genotype-phenotype correlations in other parts of the gene than last two exons? Something, not much. We have a very peculiar exon 344, which contains, now we know of more than 20 missense, pathogenic missense variants causing dominant hereditary myopathy with early respiratory failure. And there should be cases in Egypt as well, but I don't think
We have.
Okay.
Today,
Okay.
Dr. Maha will present a patient with the gene,
Yeah.
and we have, but I didn't have the time to collect our patients.
No.
But what is professor said that these patients previously undiagnosed, and these are one of the most important causes of distal myopathy with respiratory affection, with cardiac affection. Now, by the use of MRI and the use of genetic diagnosis, he can differentiate and diagnose many of them.
Very good.
We have
Very good, yeah. Okay, so, but we still don't know why this specific exon is causing that type of specific disorder. Anyway, that is what it is. And we have, if you have biallelic truncating variants, the outcome is very variable, usually congenital tendinopathies with a spectrum of severity, and either cardiac or not cardiac, and if we have even fetal lethality, we will come back to. And then we have these meta-only exons, those exons that were important in fetal life, but not later on, after birth. So those who survive, they will have a congenital non-progressive, usually arthrogrypotic phenotype, or they will die in utero. We have some understanding of exon 359 with biallelic truncating variants causing usually the most severe types, so either fetal lethality or severe congenital with progressive evolution. And then we have some understanding of biallelic truncating variants in exons 360 to 362. These are can be associated with the Emerodryphus-like phenotype without cardiac involvement. And then we have some new, the intragenic dominant in-frame deletions, very variable phenotypes. We have all from congenital forms to late onset distal, and again, either with or without cardiomyopathy. And as I indicated previously, 1% of us carry a truncating variant on one allele. So usually not causing disease. But we have exceptions. For all rules have exceptions, unfortunately. And we have exceptional families where a truncating heterozygous variant may cause a dominant titinopathy. Again, variable phenotypes, all from early to late onset, proximal and axial with cardiomyopathy. So just to let you see the Emery-Dreyfus phenotype, upper limb involvement with contractures in the elbows, the scapular winging, and also the MRI phenotype is different, and we for some reason have calpine deficiency on Western blotting as a peculiar finding in this. To the congenitals, these are one of the first descriptions of congenital titinopathies. You know Mustafa Salih, and he reported these, and then the genetics was identified later. And after that, several different reports on a large variability of these congenital isoforms. You see the arthrogrypotic phenotype here. This is a milder on the left, and cardiac phenotype
I
and
think
scoliosis.
I have a family,
Yeah.
autosomal recessive, and two brothers and one sister. They have a many-core disease in the muscle,
Yeah.
and the genetics they have a titin mutation.
Yes.
So
Yeah.
maybe you must
All
see
you
this
have
family.
them, yeah, and
yes,
you will
yes.
have them all over the world, also in Egypt, in large numbers, in fact. So one of the new features is, of our understanding is the fetal lethality with arthrogryposis. It was first indicated some years ago, but now we have with us Maria Francesca Di Feo from Italy, working on these specifically, and she has identified a number of these cases, and if you have repeated miscarriages, that can be suspected for severe titinopathy. If you have several prenatal anomalies and even syndromic phenotypes, can also be associated with background of titin, biallelic titin variant. So again, large spectrum, and you can see here these prenatal lethalities. But for the genetic part, if you have a biallelic truncating titin variant finding, this is a definite diagnosis for sure. And you just have to clarify what it means and what all organs can be affected. One sort of quite common phenotype is this posture of the arms, and also the legs can be frog-like, so can be of some hint. We working together with others on a large cohort of international congenital titinopathies, and this has just expanded over time. Our recent cohort still contains also unpublished cases, and you can see you can have even dysmorphic features, even if titin is just muscle. But if you have severe muscle problems in early development, it will secondarily affect your skeletal development. So that's why we can have these dysmorphic-like features. And of course, this means that a large number of other doctors than neurologists need to be aware of this. So we have all the gynecologists, the perinatal specialists, pediatricians, and genetic counselors. Because if you are counseling a family with several miscarriages, the geneticist has not previously considered titin as a problem for that problem. Anyway, this is just to show the anomalies. You can, of course, even observe in utero if you are looking for that, and example of mutations that can be causing this type of prenatal. MRI is again extremely helpful. So here is an example of a patient with a variant in that meta-only exon region, exon 199. And this young child is just a few months old. And so you can see most muscles have not developed at all. They never started. So on the lower legs, you have only some remnants of muscle in the anterior region, where all other muscles are not there at all. On the thigh level, you see some muscle tissue in rectus femoris and in adductor longus and vastus medialis, but most other muscles are not there at all. They never developed amyoplasia. Same on pelvic level, no gluteal muscles practically, and on the upper limbs, the same thing, just some in the shoulder regions. And that was a young child, just a few months old. When these grow up, as I indicated after birth, these exons are not used. So the muscles that survived the prenatal period after birth, these muscles can develop. And what you see is now that you have some muscles fairly well developed, whereas those that never started, they cannot, of course, come again. And you have no gluteal muscles at all, but just in gluteus medius and minimus, so gluteus maximus is totally absent, and the same on the scapular level. Some muscles are not there at all, whereas those who could overcome the fetal period, they develop. Very peculiar. But we have other types with of variations which muscles developed and clarified the fetal period or not. Just some examples shown here. Then, of course, we have in the congenital field also these with severe congenital weakness, but not the amyoplasia. You see muscles here practically in all muscle regions. They are just atrophic and degenerated, and this type of congenital tendinopathies are usually then also continuing to get worse over time. So very different developmental developments after birth. Just to end up, show you expanding number of recent publications. It's just exploding the field of tendinopathies, and this is just to let you know that we have not seen all in titin yet. We need to learn much. Some take-home messages. We have, as I indicated, some understanding of exon 359. If you have biallelic or truncating variants here or in the meta-exons, you will have a severe end of the spectrum, but the further evolution can be different. As indicated previously, if you have the meta-transcript exon variants, you can even improve after birth, which is a good sign. And then we have these severe forms of arthrogryposis multiplex congenita, which includes very many different genes and syndromes, but you have to think of titin also in these phenotypes. So we have new collaborations for the congenital titinopathies, and here just to indicate some of the people involved. And then, of course, our other titinopathies also contain a large number of persons all around the world. So thank you so much.
Thank you, Professor Ott, so much. So you know that the titin gene is one of the large. Which is largest, dystrophin or titin?
No, I said in the beginning that titin is 8 times bigger than dystrophin.
Oh, I don't know this. So titin is 8 times bigger than dystrophin gene. So that's why there is congenital myopathies, arthrogryposis, distal myopathies, limb girdle muscular dystrophies, and as you see, the clinical, MRI, and genetics. Now, you can diagnose many and many patients. I believe in Egypt we have many patients, so I will start to search for our patients. And if you permit me, I will need your presentation after you finish, because I will collect the patients in the unit and send to you to discuss which of which, and maybe we can find a founder mutation in Egypt, especially that family. I did for them muscle biopsy, and I found a multi-mini core. So yes, probably I have this family and following up them until now. Thank you, Professor, so much. Is there any questions? Of course, the lecture was very difficult, but very nice. And you see how the world collaboration to diagnose many and many new disorders. So I think we will start the patients. We have only delay 5 minutes, so we are lucky that we are on the schedule. Yes, yes, only 7 minutes delay. It's okay. So we will start the patients. Now we have very ambitious neuromuscular specialists and consultants with us. We will start, of course, we will have for every patient only 20 minutes, not more. So please, wake up, please. And first is Ghada Ahmed El-Hawari. Ghada is a neurology fellow, Egyptian Medical Syndicate. And Ghada will present a patient to us. After Ghada will present her case, we will be start a discussion with the professor and discussion with all of you. Okay? خلصتي الأكل كله؟ خلص. يلا يا غادة. يا آية مكاوي معانا؟ طب عايزة آية مكاوي.
Good morning, dear professors. Good morning, everyone. My name is Ghada Ahmed El-Hawari, a fourth-year fellow of the Egyptian Fellowship of Neurology. My name is Ghada Ahmed El-Hawari, a fourth-year fellow of Egyptian Fellowship of Neurology at Ain Shams University. Today, under supervision of Dr. Rana Zakaria, will present pediatric myasthenia gravis, a diagnostic challenge between autoimmune and congenital forms in 7-year-old girl. Our patient is 7-year-old female. She's a kindergarten student. Her chief complaint, the patient has been experiencing horizontal double vision for the past 2 years.
لا اتكلمي على مهلك عشان نفهم انت بتقولي ايه.
Okay.
يلا.
The patient has been experiencing horizontal double vision for the past 2 years.
How old is she?
7 years old.
7 years.
Yes. No negative consanguinity in her parents, no family history of neuromuscular disorder, no autoimmune disease reported in immediate family member. No significant prenatal history. She achieved all developmental milestones on time, a relevant past medical history. History of present illness, the symptom began approximately 2 years ago when she was 5 years old with mild intermittent dropping of the left eyelid. Alongside this, a left eye divergent squint developed, especially noticeable in the evening after a day of activity. Over the following month, the ptosis became more frequent and began to affect both eyes. At the same time, patient also noticed seeing object as two next to each other, which was insidious in onset painless, which improved in closing the right eye with no local eye manifestation. The symptom accepted diurnal variation with significant worsen as the day progressed. Over the next 7 months, she began experiencing generalized weakness and easy fatigue. The weakness is particularly noticeable in the proximal muscle, affecting her ability to perform activity as climbing stairs, getting up from a seated position, and carrying objects. The child reports significant fatigue following minimal exertion. The symptom exhibit a diurnal pattern with worsening throughout the day and improvement with rest and sleep. The impact of her condition has been significant, contributing to her dropping out of kindergarten. There are no muscle cramps, hypertrophy, atrophy, or fasciculation. The weakness is not associated with any gait abnormalities. The patient also developed difficulty swallowing both solid and liquid, more with liquid, with episodes of shocking and nasal regurgitation. Parent didn't report any speech abnormality. Recently, the patient complained of shortness of breath, primarily during physical exertion or later in the day. No other cranial nerve affection, no autoimmune manifestation, no sensory affection or cerebral affection, no cardiac endocrinology or systemic disorder affection. In 2023, the patient has evaluated by a neurologist and EMG studies and started on pyridostigmine and prednisolone following her diagnosis on myasthenia gravis. After beginning treatment, there was some improvement in her ptosis and squint. The key question is this a congenital myasthenic syndromes or autoimmune myasthenia gravis? On physical examination last week, the child is well nourished, alert, and she's cooperative. She's wearing glasses for distant vision. The child appears slightly fatigued, particularly toward the end of the examination. General examination is unremarkable. Vital sign was normal. The cranial nerve, the optic nerve was intact. The visual field are full. There are no evidence of optic neuropathy. Pupils are equal and reactive. There's mild ptosis observed in both eye at rest, which increase in severity after sustained upward gaze for 30 seconds. Full range of movement in all directions, but the child reported horizontal double of vision. Diplopia resolved with closing the right eye. Facial sensation was intact. Masseter and temporalis muscle strength is normal. Symmetrical facial movement. The child can close their eyes tightly and smile and puff of their cheeks without difficulty. No fatigability observed during these movements. The speech was clear with no nasal quality. The gag reflex was present. Swallowing was slow with occasional difficult initiation of swallowing of solid food. Cranial nerve accessory, the child was intact. Hypoglossal also tongue movement was full and symmetrical, no deviation, fasciculation, or atrophy. The motor system, the strength was grade 4 positive in all major muscle group approximately. Distal muscle strength was intact. There's weakness is raising from a seated position. Fatigability, the significant fatigability noted during repetitive arm movement. The child strength decreased after a few repetition of shoulder abduction. The deep thunder reflex was elicited in lower limb and upper limb, except absent in biceps reflex bilaterally. Plantar reflex was flexor, no pathological reflex. Coordination was intact. Gait is normal, and sensory was intact in all extremities. Respiratory examination was normal. We did, to exclude autoimmune myasthenia gravis, acetylcholine receptor antibodies and anti-muscle specific kinase was ordered, and 2020 was positive, but repeated in 23 and 24, and it was negative. To exclude congenital myasthenia syndrome, whole exome testing was ordered, but still pending a result. In 23, she done EMG, abnormal stimulated single fiber EMG carried out from both orbicularis oculi muscle, show increased jitter and blocking in 7 of 40 pairs. 24 repetitive nerve stimulation showed decremental response. She had normal thyroid profile, normal labs. CT chest was normal, no thymoma indicated. Pulmonary function lab show mild obstruction, normal echocardiography. So the discussion point here, the primary challenge in this case is distinguish between autoimmune and congenital form of myasthenia gravis. Early onset of symptom, negative autoimmune antibodies, and lack of complete response to pyridostigmine suggest congenital, and the lack of family history suggests a sporadic form. However, autoimmune myasthenia gravis with seronegative status remain a possible differential diagnosis. Bending genetic test will provide clarity for diagnosis and guide further treatment. Thank you.
Ghada, thank you very much. I observed your presentation. It's excellent presentation, but you are talking very rapidly. I know because of the time. What do you think, Professor, about this case?
Hard to say. Okay, so I wonder, the antibody testing was first abnormal and then it turned normal. Was it just something wrong with the first testing, or?
Yes, maybe. How much it was first test?
The antibodies.
Receptor antibody. Positive cam. What is our time? Number. We will
Again.
ask the patient.
Yeah, but
Sometimes we have some laboratory.
yeah, I mean, if you have two negative testing afterwards, I would trust that more than the first positive testing, maybe, and also because both ACR and MuSK were positive in the first place, which is also a bit peculiar. So I think that first testing was perhaps not correct.
Yes, we have the patient. Okay. أهلا. اسمها إيه؟ أسيل. تعالي يا أسيل. Okay, طب خليكي هناك. Okay. إحنا كلنا نقعد مكاننا. We will be all on place, on chairs, and please the video will be on the patient, and the professor will be with the patient. Because طلعيها تقعد على السرير كده. اقعدي يا ماما. Because this is very important. When you have a myasthenic disorder in childhood, how to think? Is it a congenital myasthenic disorder or autoimmune myasthenic disorder?
I mean, the repetitive stimulation testing should be more or less reliable.
Okay. It's a decrement.
If there is, yeah,
Repetitive test. Decrement.
yeah. Yes. Do you know the how much decrement and?
Was it more than 10% or 20%?
طيب احنا هنشوف الاول هي عندها myasthenic disorder. هنشوف النيوروفيسيولوجيكال study اللي عندها. She had a single fiber with increased jitter and blocking.
No decremental.
No. It showed 13% and 10% decrement, stimulation of the upper limbs, and also deltoid showed 23%.
So that should be.
I think it's true.
It's considered.
If more than
It's considered. وهي عاملة كمان single fiber. Do you believe in single fiber? There is increased jitter and blocking.
Yeah, could be good
Okay.
to repeat somehow. Yeah. Hello. So.
ازيك؟ كلميها بقى.
ازيك يا قولي دكتور ازاي قولي good morning.
You don't see much of abnormality.
Yes.
So it.
She's cute.
Yeah, nice lady.
ما تخافيش. كلمي قولي الدكتور سلمي على الدكتور.
hello professor. Hi.
كلمي الدكتور.
بصي معاه.
Can you follow my thing?
شوفي بصي على صباع الدكتور، بصي الناحية التانية. يلا.
But she indicates some.
There is extraocular muscle affection.
Some
Yes. ممكن نقلع النضارة يا أسيل؟ Yes.
Okay.
Diplopia. But she has some extraocular muscle affection, especially in the left eye. بص شاطر. هي واخده مستينون دلوقتي، واخده مستينون. ده ممكن يغير طبعا نيوروفيسيولوجي ويغير الكلينيكال بتاعنا. يلا غمضي عيونك قوي، غمضي كمان.
So are there any other major clinical issues than the eyes, diplopia, currently? Is there any other? Yes, other weakness than in the eyes?
لا خدي حبيبي كده.
Complain from easy fatigability. Difficult from to climb the stairs and
Yes. Yeah.
this is easy fatigability and generalized weakness that is most complaint right now.
Yeah.
And repetitive.
So can we ask her to make
The gower side.
yes,
The
yes.
squat. بصي تعرفي تنزلي كده يا ياسين.
Squats maybe 20 times.
انزلي بس كده. ايوه كذا مره ورا
اقعدي
بعض.
واطلعي كذا مره يا أسيل.
ايوه شطوره.
شطوره يا حبيبتي. كمان يا ماما.
Mm.
ايه الجمال؟
Very good.
شاطره.
تاني
هو احنا بنزود الفتيك كده. اوكي.
Oh,
enough.
10 more.
Yeah.
No.
اوكي.
And
بس نضغط
can't
كده.
see much, of course. The difficulty with children is that you can't really ask to test everything you would like to test. So you have to just interpret what you see to some extent. There was never any problem with eating. How does it appear? How does it? How do you see it? Okay, so that's anamnestic information. That is just how she and the mother tells you. Okay. I have some difficulties here, of course, to know exactly what is going on, because the symptoms are very mild. I do not even see much. We have to rely on the neurophysiology that there is something wrong in the transmission, maybe, but I would certainly wait now for the genetics first, and if the genetics do not prove anything, then I would just continue the follow-up. I would even take off the medication at some point and see if the symptoms clearly get worse, because now we do not have a full understanding of that transmission problem. It is anyway mild, and so we have time to sort of see what this will be about. And of course, lack of family history does not exclude congenital myasthenic syndromes, because we have many recessive disorders.
يعني ده اللي احنا فعلا بقينا بنعمله دلوقتي. إذا if there is no evidence that this is an autoimmune, especially when we found the antibodies are negative, we must do genetic testing. Usually we do a whole exome sequencing, and we have many types of congenital myasthenic syndromes. Some are presynaptic, some are postsynaptic, and they have different ways of therapies. So this became a mandate to do genetic testing for children with myasthenic disorders, right?
Yes, and we do not even know all genes in genetic myasthenia. So But of course there are already some 20 genes known. So
اوكي اوكي طيب في اي حاجه تانية يا غاده؟ اوكي افتكري البنت دي هنعمل لها ان شاء الله تحليل جيني، انا هعمله لها باذن الله. شكرا يا اسيل،
Very
شكرا.
Thank
باي
you.
باي حبيبي، باي باي، يلا شكرا. فكريني عشان ننظم لها تحليل جيني ان شاء الله. اوكي next case we have دكتور سمية حمدي اسماعيل. سمية is assistant lecturer Ain Shams University. She will present a patient with limb girdle syndrome. Which patient? I think he's my patient, not my patient. شكرا. يلا سمية. احنا مركزين ولا نمنا؟ لا انا شايفه ان احنا نمنا كده. يعني ان شاء الله كده 3 حالات وهناخد كوفي بريك، فاستحملوا شويه معانا. يلا يا سمية. مش سامعين حاجه، خدي المايك.
Good morning, dear professors. Here is our case, 33 years male, patient, married with no offspring, work as an HR manager, lives in Monofea, complains of bilateral lower limb weakness. Family history, here is our pedigree, with multiple affected males from maternal side, which suggestive of high probability of X-linked pattern of inheritance. Past history irrelevant. History present illness. Condition started in gradual onset, progressive at age of 4 years ago, when the patient started to notice bilateral lower limb weakness, proximal more than distal, with difficult going upstairs, mainly associated with infrequent muscle cramps. 2 years later, patient started to have or notice decreased circumference at anterior aspect of thigh, disproportionate with increased circumference of calf muscles. All through history, there were no exercise intolerance, cranial nerve affection like facial, bulbar, neck muscle, respiratory muscle affection, sensory, autonomic, cardiac, endocrinological manifestations, systemic disorders, no diurnal variation, fatigability, myalgia, nor myotonic features. On examination, general examination, no abnormality detected except laxity, very mild laxity in joints. Neurological examination, mental state, cranial nerve irrelevant, motor, there is atrophy including thigh muscles and pseudo hypertrophy in calf muscles. Tone, no tone changes. Power, distal upper limb weakness, grade 4 plus weakness in hand grip, proximal lower limb weakness, weakness mainly in hip flexion and adduction, and very, very mild weakness of knee extension. Reflex brisk in lower limbs, sensory normal, gait no abnormalities.
There is asymmetry between the left and right.
يعني
Asymmetry in atrophy and weakness.
very, very mild.
It looks okay. هنشوف.
Investigation, nerve conduction came normal of lower limbs and EMG myopathic pattern of both vastus medialis along with mild patchy affection of right tibialis muscles with no evidence of ongoing denervation. Gluteus muscle, no abnormalities. CBK total was 1,020, declined to in follow-up to 657. E's are normal, thyroid and vitamin D normal. Echo were normal. Muscle biopsy from biceps show dystrophic changes and suggestive of progressive muscular dystrophy. Or the all he done.
What is wrong with this patient?
The mode of inheritance suggestive in X-linked was suspected in his limb girdle and the upper limb weakness and distal weakness he having
Okay, if you have X-linked inheritance, and how old is he?
33.
33. And the condition started in 29.
Mm.
Is he has calf pseudohypertrophy?
Yes.
What is the first differential? What is the first diagnosis?
He suspected limb girdle.
No. X-linked.
Yeah, no,
Pelvic girdle weakness. And started in adult. What is the first differential diagnosis? Becker muscular dystrophy until proved otherwise. And then the limb girdle, the metabolic, all of this. So, because your family pedigree is very nice, this is very important to consider Becker number 1. Then, other limb girdle, what limb girdle will have this age and this calf pseudohypertrophy? Did you read about this? Dysferlinopathies. Okay.
No, just a quick question. You said that the weakness is distal more than proximal, or proximal more than distal? Because I'm not
upper
sure.
limb,
Upper limb is
distal.
unaffected, or distal.
Distal.
Okay, only distal, and the lower extremities are
Proximal.
So proximal more than distal?
In upper limb, in lower limb.
Proximal more than distal.
Mainly.
Okay.
This is abnormal in this patient. The presence of the distal affection upper limb, this is not common in Becker.
He didn't notice
So
that.
you didn't notice, but you found in examination. So that's why she think what is the X-linked and to give like this. And the muscle biopsy, unfortunately, we don't have the antibodies for about 1.5 years now, so no immunostaining was done. It is only dystrophic changes. What do you think, Professor?
We need them.
Breast. Breast and lower limbs.
Breast.
Breast.
We need a muscle MRI.
Not done yet.
Okay, but yeah. I just to let you know, if we consider a patient with muscle symptoms undergoing examinations for a neuromuscular disease, if we think the patient needs an EMG, we also order MRI at the same time. Always.
We do this in the clinic. As you saw first in the lecture, the MRI whole body will give you clue about is it dystrophic, is it neurogenic, is it inflammatory, and the pattern of MRI distribution of muscle.
I have a comment. So he doesn't have weakness in his biceps muscle, is that correct? No. So I think if we have chosen another muscle for muscle biopsy, I think it will give more information, because biceps showed only non-specific changes like some regeneration.
Yes, but it will be good enough because it was considered dystrophic and apparently with some necrotic fibers, I would guess. So, and some fibrosis maybe, so it will be good for further studies if needed.
You want to see the patient?
Yes, now we will go and see what happens.
Can
I ask him to take off shoes and
الجزمة والشراب. اسمك ايه؟ عبد الستار. شراب لو سمحت. هتيجي هنا؟ تحب تصور من هنا؟ انتي خليكي جنب العيان وهو يجي يصور من هنا. ارفع البنطلون لفوق يا حبيبي. لا لا اتس اوكي. نفسي العيان لما يجي يبقى لابس واسع. دكتورة نرمين ما تيجي قدام، ما ينفعش كده. طب تعالي بس عشان نتكلم مع بعض، تعالي. طيب ممكن نلبس جاون؟ هو عايز يشوف على رجلك. You can't. Okay, it's okay. طب ممكن تنام؟ Do you want him to lie? And
No.
Okay, خليك يا بابا.
You can first
امشي كده على مهلك خالص.
just walk normally.
امشي عادي، امشي عادي. Okay.
no waddling.
But he has calf pseudohypertrophy.
Yeah, apparently something.
Yes.
So now you can walk on toes.
يلا على طراطيف صوابعك. مهم قوي ده عشان الكاف ماسلز يا جماعة.
Okay, turn around and come back on the heels.
امشي على كعوبك.
Okay.
Not so bad.
So does not look perfect.
This
The toes go up, but the foot does not go up 45 degrees. It
Okay.
should go, I'm 75 and it should still go up 45 degrees.
This is very important for tibialis anterior. The toes go up, but the dorsum doesn't go the 45 degrees. So this is maybe he has tibialis anterior affection.
Something in the distal parts of the lower.
Yes. Okay.
And now you can then.
اقعد بقى تحت وقوم. يلا. يلا قوم.
Okay. So he needs some help. Yeah.
So he has proximal affection and distal affection.
Okay. And you can then raise your arms and keep. And bend your arm.
خد ايدك عليك.
Fine.
يلا افردها.
Full power and extend. Yeah, no problem. See how it is. So up with the fingers, up. Yeah. And spread out.
يلا هو بيشوف الديستال muscles طبعا.
There is something.
Okay. So he has mild distal weakness of the hand.
Flex. Quite good. But, okay. No major atrophies can be seen, but still something in the interossal probably. Okay. Do you think both sides are equal or?
I think he has asymmetry between left and right, upper limb and lower limb. طب ممكن نرفع القميص لفوق؟
No, it's okay. Just bend
خد ايدك عليك.
and
افردها. Extensor, mild extensor affection. Extensor of the elbow. Distal again.
so just very mild. Yeah, not too much. There is some interossal, maybe. And then lift up the arms again and keep. So here it is, but it's just 5 minus, not much. And down again here also. No problems with eating or.
الاكل ازاي وبتبلع كويس؟ الاكل كويس. انت في فرق بين حجم الناحيه الشمال واليمين. طب انت ممكن تقلع القميص؟ فيهاش حاجه بقى، دول اخواتك. اصل انا شايفه asymmetry. This is not common in Becker. This is not common Becker to find a distal weakness in upper limbs and to find this لا to find this asymmetry. فيش facial affection. بص. I found asymmetry.
FSH is not X-linked. Very clearly in the family. Yeah.
Professor, I found there's a difference in the size, right?
Yeah.
Yes.
But not much. Not much difference.
Not much. I saw in the lower limb in the photo. So we need whole body MRI muscles. تفضل البس. This is very important to know the affection. No facial affection يا دكتورة هبة.
So I would like to know from him in his sort of relatives, older relatives, with the muscle problem. Are they? What is their performance at the age of 60?
خال مامتك واخواتك وولاد خالاتك لما كانوا كبار.
لا هم مفيش، هو اللي جاله المرض فقط ماتوا بعد سن كبير يعني عدوا 60.
اوكي.
وهو مظاهر المرض عندهم فوق ال 40 كان شرس معاهم، يعني كان كفيل ان هم ما يخلوهمش يتحركوا خالص.
Okay, so he said that his relatives they started اتفضل البس started at above 40s and it was very severe that they have a weakness and loss of ambulation.
At what age do they lose walking?
Died over 60.
Very interesting. We need to solve this.
Yes, this is very important.
So we need.
Yes.
So we need trio exome sequencing, trio genome, the parents and him at least, and I would collect more samples of the larger family, as many as possible.
Yes.
We have one new X-linked muscular dystrophy. We reported a totally new gene a few years ago, SMPX gene.
What is it?
SMPX gene.
اكتبي لو سمحتي.
SMPX gene. Small muscle protein X-linked. With the founder mutation on Malta Island. I was there visiting families a few months ago. And we have other families with other mutations in other countries. It is usually more distal than what we see in him, but his disease is so early, at early stage. And there is also asymmetry.
Yes,
can be.
Yes, it is asymmetry.
This is, of course, of the currently known X-linked muscular diseases. SMPX would be on top, but I'm sure there are still other unknown genes as well to be explored, and we have to find that.
اوكي طيب اكتبي بقى اللي هنعمله العيان ده. خدي قلم اهو. Suspected SMPX gene. Okay, SMPX gene. This is an X-linked inheritance, and we need number 1 to do whole body MRI to him. Number 2 to collect DNA. We can do in our lab. For the patients, الوالد والوالدة موجودين؟ مش موجودين. Father and mother died. طب مين المصابين؟ حد من المصابين لسه عايش؟ his brother, ها؟ والcousins maternal side. Maternal.
The gene has he has had his faulty gene from his mother.
Yes.
Who is healthy.
But mother and father died.
So
brother.
Brother, sisters of the mother.
Yes. خالاته موجودين. اوكي اوكي. طيب هو ممكن البروفيسور يساعدنا ان احنا نعمل تحليل جيني للعيله، بس طبعا الحاجات دي بتاخد وقت لان دي عيله لازم تدرس. فاذا احنا وصلنا للجين المسؤول هنشوف اولا هل حاجه لها علاج ولا لا، تاني حاجه هيساعدنا ان الكلام ده ما يتكررش في العيله اللي بيسموها النصيحه الجينيه. فدكتوره سميه you are responsible for this case please. You will do for him whole body MRI. انتوا ساكنين فين؟ طيب okay, he will come next Sunday اجازه. We have okay, we will give him a time appointment to collect DNA from his brothers and aunts, one of the aunts or the aunts, okay, and follow up with me. تمام؟ شكرا لك. Sisters.
Because we don't have the mother, we need to have more samples.
الايه؟ الرeflexes. What is the reflexes? Brisk. Reflexes brisk. Wow. What about the MRI brain? Okay. Please ask Dr. Hussam Saq to do MRI brain with the whole body MRI muscles. What about the reflexes? طب اقعد يا حبيبي. اقعد كويس. And asymmetry. This is okay, not so much. Okay, الانكل, but this is a distal one. حد يجيب لنا كحول يا جماعه. لا not بريسك يا دكتوره نرمين. طيب اعتقد دكتوره نرمين ان حضرتك لازم تعملي له a good family pedigree. خلاص يبقى حضرتك هيبقى معاكي الكونتاكت بتاعه هيقعدوا مع دكتور نرمين. She will do an extended family pedigree and we will collect samples from the patient, brothers, sisters, aunts and maternal cousins. Okay, as many as possible. هي دي الطريقة اللي بيشخصوا بيها. And maybe it is a new disease, maybe a new syndrome.
Anyway, either it is SMPX or a new gene, and in any case, if we can solve this, it needs a special report.
Okay, I hope so. طيب دكتورة سارة بهاء. دكتورة سارة أثبتت الحقيقة شغل ممتاز. She's a very hard worker as assistant lecturer in neuromuscular specialty. And Sarah Baha will present a case suspected mitochondrial disorder, mitochondrial myopathy. اتفضلي يا سارة.
Okay. Good afternoon, dear professors and colleagues. Thank you, Dr. Nadia, for this wonderful presentation. Okay, so we're going to start this case. Mr. M.A.M., 27 years old, male patient, born and living in Cairo, single, used to work in a grocery shop, currently unemployed. No special habits of medical importance. Complaint, bilateral upper limb and lower limb weakness. This is our family pedigree. He has consanguineous parents. There is a family history of weakness in distant relatives. However, the history is unclear from the mother, but she reported that the offspring died at the age of late 20s. They were, however, undiagnosed. So we have a query family history of similar condition, no other neuropsychiatric disorders, no history of early onset dementias. Our patient is medically free by history. He has delayed mental milestones. The condition started with a gradual onset, progressive course of 2 years duration. At the age of 25 years old, patient started to complain of bilateral lower limb weakness, evident that he was unable to climb stairs, followed by upper limb weakness, right equal to left, proximal more than distal, associated with atrophy noticed throughout the past 6 months. The patient also complained of dysphagia, more towards solids, with unexplained vomiting related to meals, and this was associated with weight loss. All through the history, there was no diurnal variation, no cranial nerve affection, no sensory, cerebellar, autonomic, or sphincteric affection, no affection of consciousness level, no myoglobinuria, no relation to heat or cold, and no previous history of exercise intolerance. In general examination, the patient has high arched palate, no contractures were noted. Neurological examination, a patient is conscious, attentive, and oriented. He has slurred speech. However, the mother comments that this is his baseline since he started talking. Cranial nerves, what was positive that the patient had elicited brisk jaw reflex. There was no hearing loss or tinnitus. there was neck muscle weakness, flexor more than extensor, and there was tongue tremors, not fasciculations. State, there was no fasciculation. However, there was muscle tremors noted in contracting muscles, and I have a video, I will show it now, with proximal atrophy in both upper and lower limbs. This is, the patient was extending the knee, so there was tremors noted. They stopped when the patient flexed his knee. I don't know if they're evident or not. Okay. When he flexed the knee, it disappeared. Bilateral. Going back to the state, there is proximal atrophy in both upper limb and lower limbs. Hypotonia noted around the ankle and knee joints. Yes, there was also this noted around the scapula. I wanted to take your opinion as well, professors, in it. My opinion that it was not fasciculations, it was more like contractions. Yes, it does.
It looks like a replica.
Yes, yes, it does.
And it comes after, but here it is more obvious than when you show the patient.
Yes.
This video is more
Yes,
obvious.
it's more
When
evident.
she do a tapping, there is a percussion, there is muscle contraction. And take wave, looks like a rippling. This is very important because we have a rippling muscle disease. It could be genetic, it could be autoimmune. This is very important. And sporadic, and no family history.
There is query family
What is the
history.
query? Sorry.
They said that there was a problem with walking, and they deteriorated and died around the age. Oh, okay, and that they had problem with walking. They had weakness. Distant relatives.
Distant.
The previous generation.
In the previous generation. Difficulty walking and died.
They died earlier.
Yes, they died about late 20s, early 30s.
Looks like a sarcoglycanopathy.
Okay. Another.
Recessive, yeah.
Okay. But this is very interesting.
Yes. Okay.
Why you said it is mitochondria?
Because the patient had cognitive impairment. He has delayed mental milestones. He also is having abdominal troubles, recurrent vomiting. So maybe this was with spectrum of mitochondrial myopathies.
Metabolic?
Maybe.
Could be a metabolic.
Yes. Okay.
This is his MRI.
This is the single muscle examination. To say it in short, the patient had proximal more than distal weakness, and around the elbows it was extension more than flexion. Supraspinatus muscle was affected, and neck flexion as well was affected. In the lower limbs, there were neck flexion, yes. In the lower limb, again, around the knees, extension more than flexion, and around the hip, it was flexion more than extension. The patient had right mild winging of scapula with no trunk muscle weakness. There was intact coordination. Deep tendon reflexes were brisk in the upper limb, and they were diminished in the lower limbs. Patient had bilateral extensor plantar, and he had a positive Hoffman sign. He had bilateral hand tremors during rest and movement. Patient had a waddling gait with intact sensory examination. Our investigation showed a mild elevation in CPK total. Pyruvate was done, it showed mild elevation. Lactate was normal. Vitamin D3 was deficient. Other lab were normal. MRI brain was just done a few days ago. It's unremarkable. MRI lumbosacral was done. It was normal. And here we have the MRI muscle. I have the fins as well if you want to see it. Our MRI whole body muscle showed that below the knees were bilateral edematous changes implicating the posterior knee compartment with mild atrophic changes in the posterior knee compartment. Thigh muscles showed mild edematous changes implicating the anterior compartment and similar atrophic changes with the same distribution and involvement of the pelvic girdle muscle in the form of vastus lateralis and to a lesser extent the gluteus maximus muscle with similar atrophic changes with the same distribution. However, there were no edema or fatty atrophy noted in the back, paraspinal, anterior abdominal, chest wall, shoulder girdle, arm and forearm muscles.
يعني هو الحلو هنا ان هم عاملين لنا الام ار اي برين مع الام ار اي ماسلز، وده بقى مهم جدا خصوصا في الحالات اللي احنا ميتابوليك ميتوكوندريال سسبكتد كونجينيتال سيندرومز او كونجينيتال ماسكولار ديستروفي. طبعا وجود الايديما في البيلوني ده مهمه، يعني edema of muscles and bilateral edematous changes واخد البوستير compartment. هو الأنصت بتاعته كانت امتى؟ 2 years ago.
Yes. He also, there was an accidental finding of left hepatic lobe lesion for further ultrasound assessment noted in the MRI whole body muscle, and the impression was that it was suggestive of limb girdle muscle dystrophy.
What is MRI?
That it's suggestive of limb girdle muscle dystrophy.
Why it is not necrotizing myopathy? With edema of the below knee of posterior calf?
Yes.
No, we must search for, this is only 2 years ago.
Yes.
Is it the cognitive impairment or intellectual? Is it related or not related?
Yes.
But we must think about acquired disease.
Okay.
Could it be a rippling muscle disease, autoimmune? What about the MRI findings? You know, now it is very important that some disorders like rippling muscle disease or caveolinopathy, previously we know that this is a gene mutation. Now we found that there are antibodies against the Cavin4 antibodies, so it is an autoimmune disorder. This is very important. Could this MRI findings, did you read about this? I didn't know about this. If it could be with this peculiar tapping and muscle movements. Did you read about this or no? Caveolinopathy, MRI findings. What is Yehiba? Caveolinopathy, MRI finding. We have to ask Dr. Odd.
I think CAV3, so caveolinopathy, is within range with more dystrophic changes on the calf muscles. On the thigh level, we have quad involvement, which is a bit more than what I have seen usually, but still within the range. We have increase of edema in the same areas, which of course are possible with ongoing dystrophic process with fibronecrosis, but inflammatory is not excluded.
Necrotizing myopathy, anti-HMGCR or anti-SRP?
so I have never seen those with rippling. And I okay.
With rippling. I have patient in Egypt. Maybe I will present in the World Muscle Society.
Yes, but I have not seen rippling with HMGCR or the other conventional.
We have a patient in Egypt presented with severe myalgias and pains and rippling muscle disease, then discovered to have a thymoma. And in Egypt, we don't have Cavin-4 antibodies, but this patient was markedly improved after removal of the thymoma. So it could be an autoimmune form. So
we need muscle biopsy.
He did a muscle biopsy in 2022. It showed mild myopathic changes.
From which and where?
From the left biceps.
Wrong muscle. Wrong muscle. It should be one of these affected
muscles.
quads or.
What you expect to find in the muscle biopsy?
The main issue is here, of course, to clarify if there are inflammatory components or not, according to the edema finding on MRI, which is either inflammatory or active dystrophic process, either or. So we need to have muscle biopsy to clarify, and also EMG could help.
EMG?
Yeah.
Yeah.
To help to see.
Yes, he did EMG.
If it is myositis or not.
Yes.
No spontaneous activity. Okay.
He did a nerve conduction and EMG on both upper and lower limbs just recently. There was evidence of lumbosacral radiculopathy with myopathic pattern, affection in all the examined muscles, and chronic denervation in lower limb muscles. He did a previous one 2 years earlier. It showed bilateral tibial motor radiculopathy.
Did it show spontaneous activity in any muscle?
No.
Like fibs, abnormal spontaneous.
Yes, there were fibs and there were joint cells as well.
So we can't exclude inflammatory components just by these EMG results.
Still pending due to affordability.
Okay, we can ask Dr. Amir Shihab. She may have extra to disclose, please, to do anti-HMGCR and my side scan. Right, and I will phone her to have this panel. Which muscle do you suggest for muscle biopsy? Calf?
Either calf muscle or quad, vastus lateralis.
Okay.
calf muscle يا سارة. كلنا ما عملناها.
The main issue, I think, sometimes. Thank you. I have a question regarding biopsy from calf muscle, because sometimes it shows denervation from lumbosacral, so we may see some denervation. But I think, yes, if there is inflammatory process, I think we'll be able to pick it up. But I will vote for the quadriceps. Yeah.
We can do from vastus lateralis or we can do in OR. شوفي كده nerve conduction يهب.
Doctor, we have the patient here if you want to start examination.
Yes, we have. Resting activity.
So some spontaneous activity.
Yes. Did you, he has these movements all the time or occasionally?
Whenever I saw the patient, he had them.
Okay. اسمه ايه؟
محمد.
محمد. بروفيسور اود هيشوفك يكشف عليك يا حبيبي. انت تقدر تقلع القميص ولا صعب؟ اوكي. يلا حبيبي. هنا مهم قوي to unburr the patient, to see the muscles. How can we see a rippling muscle without burring, without seeing the muscles itself?
Has he always been thin?
انت دايما رفيع كده من وانت صغير؟
Okay.
This is also, yes.
But you can see,
He's
even if he
very
has
atrophic.
a very thin build, body, there is clear atrophy anyway.
اقعد يا حبيبي كويس.
Yeah. Okay, so where can we see the rippling?
ورينا
Does he feel the rippling himself?
انت بردان؟ شايفاه بيترعش. ها؟ دول اخواتك كلهم. كل دول دكاتره وانت بتساعدهم، فدول اخواتك ما تحرجش منهم يعني. He has tremors all over. Or fasciculation. هتنقل الكاميرا عليه؟ اوكي. ممكن تكبروا لنا الويندو ده لو سمحتوا؟ ايوه. تمام، شكرا.
So we do not automatically see rippling in all muscles just by trying to provoke rippling, but the overall build is peculiar.
Yes.
The whole stature, the sort of
size of the head, size of the head,
everything
the body. انت عندك كم سنة؟ 28 years.
So there is some sort of increased reaction on provoking, but now we can't see rippling directly.
Can you his speech is slurred. قول اسمك كده، اسمك وساكن فين؟
محمد عبد العال مصطفى.
ساكن فين يا محمد؟
عين شمس.
تمام. وانت في سنة كام ولا درست ايه؟
مخلص.
خلصت ايه؟
قاعد أولى إعدادي.
It has been from early childhood.
Yes. He slurred and abnormal use of the facial muscles.
So yes.
High arch.
Yeah.
في high arch. طلع لسانك بره.
Okay. Can you
هات لسانك هنا.
Yes.
يلا لسانك الناحية الثانية. But as if he has tremors of tongue, tremors of body.
وبعدين عنده هوفمان هنا كان بريسك.
في هايبر ريفلكسيا كمان.
في بريسك في البريتشنز.
افرد ايدك، افرد ايدك. يلا.
So compared to the muscle volume, the power is not too bad. So bend, yeah, and stretch. Okay. And up with the lift up, yes. Wow. And here you can see the heavy weakness of the pelvic flexure, and here too, up.
I found it as fasciculation.
You
Can you
found
look?
something?
Can you look here? It looks like a fasciculation.
Maybe, yeah.
Yeah?
Now, yeah, here they came. Yeah, now, yeah. So maybe
It's a diffuse fasciculation.
I would also think that the provoking now power testing may actually provoke the fasciculations to come through.
We have a juvenile onset motor neuron disease because we started to have some. It's continuous now. It's fasciculation. You must repeat the EMG by yourself. Yes, yes. We must search. I believe that this could be in the differential diagnosis, a juvenile motor neuron disease. And the reflexes are brisk, brisk and fasciculation. And he has this slurred speech. It showed dystrophic, the MRI showed dystrophic changes and edema. It's very interesting. Plantar response, yes, Sarah.
It was extensor.
Hmm?
Yes.
I think the both are more myopathic than both.
The MRI is more myopathic. Not increase. But above the reflexes are brisk. افتح بقك. عنده very high arched palate. سارة تعالي بعيد عن الكاميرا. سارة رجعي لورا. ايوه كده. اوكي. تعالي دكتورة سوسن. بصي حضرتك. continuous. ايوه. ايوه. But coarse fasciculations. But present.
Yes, this is unusual type of spontaneous activity. I mean, you have it over a large area.
Multiple muscles.
Yes.
Very interesting cases. خلوا بالكم دي مش حالات سهلة يعني.
It's not actually typical fasciculation, and it's not typical rippling.
A new syndrome.
Something peculiar, yes, ongoing.
Something new, neurogenic and myogenic. And
we have it here too. I can feel it more than see it.
Yes. But in the muscle biopsy of the biceps, it was just variation in fiber size. No dystrophic changes and no inclusions.
No inclusions, only mild myopathic changes.
And we have the periodic acid shift and the oil red O, it's all normal. No mitochondrial changes.
No mitochondrial changes.
No, we can continue. We can continue in his muscle biopsy.
Definitely take a new biopsy from clearly affected muscle to have the clarification on that. But we probably also need genetics.
Yes, of course. طيب جيل المطرقة. يبقى احنا هنا this is a very peculiar condition and dated since birth maybe or maybe have an onset, but it looks like to be dated since birth.
And there is of course some developmental issue. We don't know if that's the same thing or if they are two different.
So this professor said this is more than a fasciculation. It's very coarse. He can feel it. It takes more than one muscle. So we will take another biopsy from affected muscle in the MRI, and we will do a genetic study to him.
Okay.
I hope next year we can follow up what happened to him. شكرا ليك يا حبيبي إلبس. You are responsible for this patient. You are responsible for this family. They lose a lot of families.
Positive gouge. It's very evident when he's on the floor.
طيب
Yes.
عشان التايم احنا عايزين نصور الكلام ده وهتعملوا فيديو للموفمنتس وهيز واي اوف سبيتش. You are responsible for this patient. Okay, last patient before the break. I'm sorry we are out of time, but because I saw that this is a straightforward patient, but لا قبل البريك حالة واحدة بس. الدكتورة مها جت؟ معلش لما تيجي. احنا انهي بيشنت اللي عليه الدور؟ طيب يبقى اذا الدكتوره مها جت we have a break now. اما الدكتوره مها تخلص هتيجي. اوكي now what is the time؟ احنا هنستنى العيانين. ايه ده؟ الساعه كام؟ يعني لسه we have time. like 30 minutes يبقى لسه البريك. طب فين العيانين؟
We have MAH. He is 39 years old male patient. He is born and lives in Cairo, divorced with 2 offspring. The youngest is 5 years old. He is a smoker, 2 packs per day. This have been happening for 25 years. Complaint, gradual, progressive, bilateral upper limb weakness. The family pedigree, 3 generations are free of the disease. He has an older sibling, male patient. He died at age of 19 years old, but he died in accident. Regarding the family history, there is no similar condition or any other neuropsychiatric or dementias. Past history, he is medically free. History of present illness, the condition started with gradual onset progressive course of 21 years duration. At age of 18 years old, patient started to develop bilateral upper limb weakness, mainly proximal, affecting left more than right. That progressed over years from just, he was in a police academy, so he used to do pull-ups. The first thing he noticed that number of pull-ups he do decreased markedly. This was the first sign. That progressed over years to an ability to raise his arm more than 90 degrees. At age of 22, patient had car accident that led to bilateral shoulder joint ligamental tear. Right shoulder was surgically repaired at age of 29 and left shoulder was surgically repaired at age of 35. Patient started to develop the gradual progressive truncal muscle weakness to degree patient can't get up from recumbent position without support. Around age of 30, patient started to develop dull aching pain affecting trapezius, serratus, deltoid, pectoralis major, triceps, and regarding the lower limbs, there was affection, pain in the adductor. This pain was dull aching, not responding to analgesic, and not responding to rest, yet increased by effort. Progressed to involve bilateral lower limb proximal weakness that progressed to degree patient can't get up from sitting position except with support. In the last 2 years, patients started to develop occasional cramps involving both lower limbs. All through history, there was no diurnal variation, no fasciculation, no cranial nerve affection, no sensory, cerebellar, autonomic, or sphincteric affection, no myoglobinuria, no relation to heat or cold, and no previous history of exercise intolerance. There was nothing remarkable in his general examination. Neurological examination, patient is fully conscious. The only thing in the cranial nerve, he has elicited brisk jaw and left flattened nasolabial fold, very mild flattened compared to the right side. adductor digit affected pilate, affected more on the left side. He has affection in the serratus and rhomboid also. Regarding the lower limb, he has only affection proximal around the hip. He has affection of hip abduction and adduction and hip extension with bilateral winging of scapula, right more than left, and truncal muscle weakness. He has intact coordination, reflexes, deep reflexes, upper limb are brisk radiating, lower limb are brisk, especially knees, adductors, and ankle. All are brisk, superficial are intact, and bilateral flexor plantar. He has a little bit wide-paced gait. He has no significance in the sensory examination, no significant finding. Regarding his investigation, he repeated the nerve conduction twice. The first one was done on both upper limb only, showed just radiculopathy. The second one done in the same year, it was done on both upper and lower limb. It shows myopathic picture, mainly affecting proximal muscle of upper limb. He done many investigations. His ESR was normal. He has done full collagen profile and it all was negative. He has done anti-H MGCR. It was also negative. He done investigation for Pompe disease, 4.8, and this is a normal value. He has done inflammatory myopathy panel twice. The one he has done in 2022 showed positive MDA5 and SEE1. It was repeated again in 2024 and it was totally negative. His CBK repeated multiple times and was normal. He has done investigation, anti-endozymal was also negative. Vitamin D a little bit low, 11.7. His echo showed total normal values. He has done MRI muscle in 2021. There was variable degree of fatty changes with no edema. In the pelvic muscle, there was affection for the gluteus medius and minimus with total sparing of gluteus maximus. Thigh muscles, there was affection of semimembranosis and adductor magnus, more on the left side. Leg muscles, there was infiltration in the right tibialis anterior, bilateral soleus, and bilateral gastrocnemius. In the upper limb, there was no fatty changes at the arm and forearm bilaterally, but the shoulder was affected, mainly the anterior fibers of deltoid muscle bilaterally. Regarding the trunk muscles, there was affection to the serratus anterior and latissimus dorsi, and again, it was only fatty change with no edema. He repeated the MRI again in a different institute in 2024. It shows bilateral, nearly symmetrical muscle fatty infiltration, to lesser extent edema with mild progressive course compared to the previous study. He has done the whole exome sequencing, showing a variant of uncertain significance of heterozygous state in MYH7 gene.
Thank you, Basma. I have to thank Dr. Basma Houeji and Dr. Sarah Baha. Both also have a very good presentation, and I have to thank Dr. Rana Zakaria, lecturer of neurology, and Dr. Heba Rashid, assistant professor, because I think they helped also in you didn't? And Ghada also. Ghada, yes, I thanked Ghada for her presentation today. I know you did a lot of effort, and these are very interesting cases. The problem is this patient, because I'm following up this patient, that is, he is complaining of pains. All the time is complaining of pains together with this progressive weakness. And he has a very important work because he's a police officer, and he has something troubles in his marital status because of his illness. So he's a problem of diagnosis. All the inflammatory panel is free. Metabolic for Pompe is free. And we did MRI several times. And now we have this whole exome findings in MYH7 heterozygous. So
what is the variant found?
Do you have the genetic study? ازيك عامل ايه؟ هيجيب لنا التحليل الجيني بتاعه. معلش اخرناك النهارده.
MYH7 is not very likely for this phenotype, but there are some peculiarities with that gene as well, so we need to have the variants in the last part of the gene. are known to cause early onset distal myopathy, Ling type. But in the very last exons, again, the phenotype may vary, and we have a hyaline body myopathy, and whereas in the N-terminal region we have cardiomyopathy. So again, different outcomes depending on where the variant is located.
This is the heavy chain, myosin heavy chain, and this is the variant. This one. Okay, he has a hard copy. It will be better.
No,
it's okay.
So this is in the end of the C-terminal end, not in the far end. So it is in the area where we see laying distal myopathy. But the phenotype is not.
Yes. Phenotype here is limb girdle and rather asymmetry. Sometimes I was thinking of a facioscapulohumeral, but yes.
Why is it not?
I don't know, but it looks like. But these pains, I couldn't explain these pains.
Yeah, so pain is always a difficult issue. As you know, even if you have a severe, heavy, lethal progressive dystrophy, usually do not have pain.
ازيك يا محمد اخبارك ايه شكرا انك جيت معانا
with myotonic dystrophies, the myotonic dystrophy type 2 is a peculiar form of myotonic dystrophy, not very much frequent here around. It's more frequent in Europe and Eastern Europe. In Finland, we have as much myotonic dystrophy type 2 as type 1. And that disease can sort of be dominated by pain, myalgic pain. The muscle weakness can be mild and the pain can be the main problem. And we have also some other myotonias, so chloride channel and sodium channel myotonias that can go with pain without much even of myotonia, even on EMG, it can be very mild or even absent. But this phenotype is different. We have clear scapular weakness developing, apparently progressive.
Yes.
And then the myalgia is sort of unclarified.
اتفضل يا استاذ محمد. يعني تحب تتكلم انجليزي ولا عربي؟ اوكي. So what is your main complaint؟ اكتر حاجه بتشتكي منها ايه؟
البين all over my body.
What kind of pain؟ تحس بايه بالظبط؟
من اول هنا كده اول الجزء ده.
Even now?
Yeah.
Does it
this muscle especially.
Does it harm your sleep? Does it harm your sleep? Okay. Is it there already in the early morning?
What?
In the
الصبح
morning
بدري
when you
بيجي
wake
الصبح
up?
بدري
ده على طول.
على طول all the time. He cannot sleep because of these pains.
And does it change when you use your muscles? I mean, you have heavy muscles you are training, I guess. It looks like. Does it get worse, or is it always the same?
No, getting worse by time.
Okay, by time, but not by training in the gym.
ممنوع من الجيم
أنا I refuse gym. only physiotherapy.
Okay.
بقالي فترة كبيرة ما بنزلش.
But
Any effort at work.
Yeah. I mean, his muscle bulk is
But
looks like
marked
he has been
asymmetry.
training.
That's why
Yes,
I was
yeah,
at the time
yeah.
thinking about FSHD
So
because of marked asymmetry.
Yeah. Yeah.
بقيت بسند ايدي مثلا على المكتب شوية بقت بتنمل، ايديا الاتنين بقوا بينملوا. بس.
الألم يا أحمد محمد، الألم ما بيروحش بأي مسكن. any analgesic help the pain.
تهيألي كان آخر حاجة حضرتك كتبتها لي اللي كنت باخدها قبل النوم دي بسم الله الرحمن الرحيم. كان حاجة اللي حضرتك قلت لي أصرفها بلجنة أو حاجة اللي هي ليريكا.
Lyrica. I gave him high dose Lyrica.
Okay.
No improvement.
مش عارف والله يعني هي ساعات بعرف أنام وساعات لأ.
Slight response to high dose Lyrica. Okay.
Where is it most? Up here in the body? Yeah,
Okay.
yeah. A neck? Yeah. And thigh? Okay.
It has specific distribution, the pains.
Peculiar.
Very peculiar.
Yeah, very strange.
At one time, I thought it is psychogenic.
Yeah.
Because of the stress of work and the stress at home. I thought like this.
And the lack of variation.
It
is always there. It's in the sleep. If you're awake, if you are doing something, always sort of hurting. And of course, once the brain has turned into a program to feel pain, it is very difficult to get out of that program. So you have many mechanisms of how pain can be sort of felt. Of course, the normal is if you have an injury to your tissues, then you will have pain, and that's the normal. But the same sort of pathways can be activated through other mechanisms than only physical injury.
Okay.
Sensitization syndrome, you mean?
There are many different ways how these programs can be activated. Okay, so we'll have a look at the shoulders. And we see some less muscle bulk on the left side compared to the right side. Then you can lift up the arms. Okay, so this, when you see his muscles, you would not expect that he has difficulties to elevate his arms. And this is, of course, one of the first signs of FSH.
FSHD.
Yeah. When you do not see much else, but they can't go up with the arms over the horizontal. And lift up the arms to that side, and now
there is scapular winging.
And you have these peculiar bulk issues here. Okay, and now you can sit down again.
Will operations complain before?
But as you know, FSH does not go with pain.
Yes.
So
and I want to ask, we have some patients with muscle distribution, clinical and MRI of FSHD and no facial affection. Is it common?
It's not common, but FSH can have 100 different faces. I have been fooled myself.
Yes.
With FSH because some patients, they start with just a distal myopathy in the anterior leg. They can't walk on their heels. The tibialis anterior is dystrophic, and it stays like that and only in the lower legs for 10 or 15 years before they develop facial weakness.
Yes.
And the same is with this arm elevation. It can be there for years before other signs start.
For Mohammed, it is very slowly progressive, taking this as if the FSHD, the asymmetry, the elevation, and the scapular winging. So clinically, it looks like this without face affection.
So now,
from muscle biopsy? Facial scapular characteristic.
Okay.
No.
So now you close your eyes very firmly, yes. And this is, here you would expect some weakness.
Yes.
But if you think hard, you could say that maybe left eye is.
غمض قوي كده يا محمد. غمض غمض غمض. The left is slightly.
It comes up to this. The right
Yes.
one is stronger than the
Yes,
left one.
yes.
But these are
Very minimal difference.
signs. So okay, and say and out with the tongue. Okay, and put the tongue here to my finger. Okay, and this. No major issues here around. Okay, and lift the shoulders. Yes. You can see here the difference, the asymmetry again. Yeah, very good. What do we need more? We need to see if there is some anterior lower leg weakness.
اوكي ممكن تقلع الشوز يا محمد. امشي على اطراف اصابعك. الاختبار ده مهم جدا تعملوه علشان الكاف ماسلز، ويمشي على الهيل علشان التيبياليس انتير. اوكي هو بيقدر يمشي تيب 2 كويس. امشي على الكعبين يا محمد. امشي صعبة شوية. صعبة شوية. اوكي اوعى تقع. رايت سايد مش مرفوع، يعني بيحاول بالصوابع لفوق بس رجله مش مرفوع. الاختبارين مهم قوي برضو نبقى نعملهم في الكلينيكال اكزامينيشن.
I would definitely first check FSH.
We have a problem in genetics of FSH.
Yeah,
What will
not only you.
I suffer with my colleagues.
Yes.
What is needed for genetics of FSH?
We
محمد.
have even sent our samples to Netherlands for the complex testing, which is very expensive.
This is for type 1 or type 2?
Yeah, but there are now upcoming new genetic techniques.
Okay.
I have not followed up that myself, but I just know that by checking these repeats and methylation issues on genetic testing, you can probably have a easy. But you need to discuss with your geneticists how to do it.
Okay.
And of course, the second gene, the SMCGA1, which is also associated or causes a FSH phenotype, the FSHD2, needs to be tested. It also goes with methylation defects in that D4C4 area. So, but yes, it's a bit complicated.
Yes. So sometimes, as you see, we do whole exome sequencing, and we have a variant, heterozygous. But the professor said that the genetic variant is not compatible with the phenotype. So I cannot diagnose the patients as MYH7 gene mutation. It looks like not related to the condition. We are thinking now, number one, FSHD, but the problem is the genetics of it is difficult. We have to send abroad for genetic testing. I can try through his hospital. They can help us if we know what genetic we need. Do you think that we need to search for myotonia type 2, or
no.
it is not compatible in this condition? Do you think we still need a muscle biopsy? Or
I would do the genetics first and then
genetics
see.
first.
If you can't solve anything that way, then we probably need.
So I hope we will write with the professor what is the genes we do, what is the testing, where is the lab, and I can try through his hospital to send abroad for the genetic testing.
And just as a general aspect, when you have these findings, in this case with the MYH7 gene, with a variant in an interesting region of the gene as such, but the compatibility with the phenotype is not good, then you would like to exclude that as having an effect. And that, of course, you can do by testing parents. So if one parent also has the variant and no
الوالدين
problem,
موجودين يا محمد؟ موجودين.
you can exclude. That's a way to exclude.
Okay.
If you wish.
So, Dr. Nermin, I think we need to see the family pedigree. دكتورة نرمين استشاري الجينيتكس الطبية معانا ونشوف الفاميلي pedigree. طب اتفضلي.
The umbilical sign for type 1 fish scapulohumeral. The upward deviation of the umbilicus.
Umbilical sign, yes.
It may
you could test that, yes.
Yes.
But I did not take off it.
عايزين بعد نكتب بقى الجينز اللي احنا محتاجينها. تمام يا محمد، احنا هنشوف ايه التحاليل الجينيه. هو مش مقتنع بالطفره اللي لقيناها، قال لا مش ماشيه مع الحاله، فاحنا هنشوف ايه التحاليل الجينيه اللي احنا عايزينها هنكتب. واحنا هنأخر العينه العضلات دلوقتي، وهنشوف برضو حكايه الالم. هو شايف ان بقى ده زي حاجه احنا بنفكر في الالم ومركزين معاه. هنشوف الموضوع ده. اوكي، شكرا ليك، وهنكتب الحاجات دي وهبعتها لحضرتك. شكرا يا محمد، الف شكر. Okay, and the last speaker, our eminent pediatric neurologist, Dr. Maha Zakaria, assistant professor of pediatric neurology, and she had some training with Professor Bonnyman in the States. She will present there a patient. Okay. هم هيدخلوا. هاتوا العيان بتاع الدكتورة مها يا جماعة. اوكي، هناك على البتاع البقلفون. دكتورة مها هتورينا حالة فيها 13 ميوتيشن بالظبط، وهي عايزة تعرف الميوتيشن اللي لقيتها دي ليها سيجنيفيكانس بالكلينيكال ولا لا. زي ما انتم شايفين الكلينيكال هو المهم، الكلينيكال فينوتايب هو المهم. هنشوفه بقى ماشي مع ال 13 ميوتيشن the clinical phenotype or not. And Professor Oud will read this genetic information.
Thank you, dear Professor Nagy, for this introduction. It was very nice, and thank you, Professor, for your presence today with us. So I'm going to start with my patient. She's a female patient. Now she's 3.5 years old. She's the second in order of birth of second cousin consanguineous parents. She has a normal male sibling and has no family history of any similar condition. She was full-term, delivered with C-section with no perinatal or antenatal or postnatal problems. And actually, she presented 1 year ago with two main complaints. Number one, delayed motor milestones, and a bit delayed mental milestones too, and one attack of unprovoked seizure. She was not sure of the fever, but mostly she was not feverish, and it didn't repeat again. So it was just one first unprovoked seizure. Upon examination, she was alert and playful. She has a normal occipitofrontal circumference, normal weight and height. She was a bit hypotonic with hypermobility of the joints. So the workup done for her was first to exclude a bit developmental delay with the motor delay. Her CK was 107, it was normal. She underwent MRI brain, it was normal. EEG was normal. TSH and workup for inborn error of metabolism, and all was normal. And patients were a bit reluctant about doing EMG or nerve conduction sense of the pain condition. They followed up with physiotherapy and intervention sessions, and actually the girl improved markedly. She walked around the age of maybe after 2 years, shortly after 2 years. And then they were keen to diagnose her, so we sent the whole exome sequencing. And actually it showed this variant and the TTN. It was a heterozygous variant. And I sent to the team and in the NIH with Dr. Bonnyman, and they reported that they saw this matching the recessive titin-related myopathy. So my question here, did you see this variant with dominant type because the mother and father actually are normal? Is there any explanation for the delayed mentality till now? Because what's matching the titinopathy is the a bit hypotonia, delayed motor milestones, and the hypermobility. And actually what's written is that this mutation is linked to dilated cardiomyopathy. So we did echo and it was normal. Yeah, sure.
Can you give us briefly what the patient has? How old is she?
She's 3.5. We can see her. نور ممكن تنزليها؟ اسمها تالا. تالا.
عندها كام سنة دكتورة نعم؟
هي عندها 3 سنين ونص دلوقتي.
3.5 years old.
اه.
And what is the presentation?
هي مينلي حضرتك كانت جايه علشان كان عندها delayed motor milestones، بس كمان لما رجعنا الهيستوري لقينا في delayed mentality وعندها hyper mobility of the joints وعندها first unprovoked seizure عند سنه ما اتكررتش تاني. delayed motor milestones a bit delayed mentality و first unprovoked seizure وعندها hypotonia و hyper mobility of the joints. الاي جي نورمال والام ار اي برين نورمال والورك اب بتاع الانبورن ايرور كله نورمال والتي اس اتش والسي بي كي بالظبط. واحنا ما عملناش اي ام جي ونيرف كوندكشن. لا عملنا كاريو تايب كمان، كانوا هم قلقانين شويه فعملنا كاريو تايب بس لا ما عملناش اي ام جي.
ما فيش نيوروفيسيولوجي ام ار اي ماسلز؟
لا not yet.
Muscle biopsy?
No.
So professor will see if this clinical variant or phenotype related to this gene mutation or not. They are thinking it is autosomal recessive titinopathy. No. مش مبسوط. اتفضلي اقعدي.
So what do we have? The sequencing has found a variant in titin gene, and you can expect what it is like. It is one of these truncating variants, so it is a frame shift variant, but heterozygous.
Dominant, autosomal dominant, recessive. Heterozygous.
Normally, 1% of us have truncating variants heterozygosly.
It's not a normal variant.
It's not a normal variant, it's a pathogenic variant, but that normally does not cause anything in heterozygosity. So it's not a dominant. No, it can be combined with something else on the other allele. It does not need to be homozygous. But you normally have to have something on the other titin allele to make a disease. That's the normal issue. I told you in my presentation that we unfortunately have exceptions to the rule. So we have just found the first family with the dominant effect of a heterozygous frame shift. But here, how many are we? 150? So there is at least one of you or us having a heterozygous truncating variant in titin gene. And now, of course, the first thing is to try to see from the phenotype, is there a clear phenotype profile common to titinopathies? If that is the case, then we need to make more search to see if we can identify a second harmful titin variant.
So we need the sequencing of the gene?
Yes, then we usually need first to have the good clinical profile, including muscle MRI, and also muscle biopsy to see the
muscle MRI مهم جدا.
yeah, that's the first.
Yes.
And if we heavily suspect, if there is a titinopathy profile on MRI, then we need, of course, a muscle biopsy, because then we have to go to RNA to search for the second hit. Because
RNA from the muscle?
From the muscle, yes. Because exome sequencing has not clarified any second hit. So there are these steps. yes. So either mother and or the father is probably carrying the same heterozygous variant. Usually, yeah. And so that is not directly a problem, but it is good to clarify, because if not, if it is a de novo, then you have more troubles. The de novo variants are sort of more committed to be more harmful than if you have the same variant also inherited in one of the parents. Okay, so yes. So my first question now, what about the brain? There was indication of some mental, developmental indication. What are these mental symptoms related to mental development?
Now she improved after the intervention session, so now she can run stiffly. She can use
Yes, that's motor.
Yeah,
but
for the
mental?
yeah, she can say like 2-word sentence. At this age, we are 3.5, and total
Okay.
100 words. Not that bad, not that
No,
good.
but no.
She cannot identify the colors yet. She
Mhm.
knows some animals.
Okay.
She starts potty training.
Yeah.
And that's it.
Okay. Yeah.
And she's improving.
Okay.
Like
Yes.
6 months
Yeah.
before she was.
But I indicated that severe biallelic teitinopathies may go with syndromic features, and of course more than skeletal malformations, but primary brain problems are not part of teitinopathy spectrum. So that makes me directly a bit hesitant. A bit of clear brain developmental features are involved.
Yeah.
And that primarily directs me to think of something else than TIT.
Do you think that sequencing of the gene is of value? Like sequencing the TT, and I know it's the largest protein, so maybe sequencing of the gene itself can be helpful to find the allele or like a compound heterozygous mutation.
I mean, it is already sequenced.
But the whole exome, not the gene itself. So will the gene itself add a benefit?
I don't really see what you are looking for. Exome sequencing covers axonal and small parts of introns in the whole gene.
Yeah.
So actually the whole gene is sequenced from a normal point of view. But of course, when we need to look for unusual second hits, then we may have deep intronic problems. And then we, of course, need to have
whole
genome sequencing and RNA sequencing to know if these deep intronic variants cause anything on the RNA transcript level. So there are multiple steps to be.
The problem is the money, of course.
Yes,
you know,
yes.
you know.
And we, it is not needed to start with that.
Yeah.
So a muscle MRI is the first step.
Okay.
And already from that you will have some sort of indications. Is there a teitinopathy profile or not? And if there is a teitinopathy profile, then we can go on to find the second hit. And then we also need to check DNA on the parents to be sure it is inherited from one and not de novo. But if there is no clear teitinopathy profile on the muscle MRIs, I would
ignore.
Yeah.
We shall ignore. Okay.
ممكن تخليها تمشي يا ماما التلات؟
كده تمشي؟
لا مش هتصور
How
ولا
is
حاجة.
she moving?
هو احنا بنسجل؟
ممكن
ممكن نوقف بس الريكوردينج؟
ستوب فور الفيديو. بلاش.
هي 3.5 مش كده؟
No
3
creatine. No creatine. So
بس
she
من
is a
غير
bit
تسجيل
clumsy
ممكن
in her walking.
Okay.
But you say she is improving in her movement.
yeah.
Okay.
She has markedly
Okay.
improved.
Thank you.
يعني آخر 6 شهور اتحسنت جدا.
اقعد.
بس can you
Should
see
I?
the hypermobility؟
Yeah.
ما تخافيش.
Okay. Okay.
بصي
I will
عايزين
sit
نوريهم
here.
هنا. بصي انت هنا اهو. بصي يا تال.
So can we check the hypermobility? Is it in all joints or that just distal joints?
ما انا قلت. طب ممكن نقلعها الشوز والبنطلون؟
عادي.
ما تخافيش يا توتي.
جايين نتدلع بقى مع بعض. ايه تاليا تاليا. اسمها ايه تاليا؟ تالا. ايه الاسامي الجميله؟ نجيب الاسامي دي منين؟ تالا. ايه. Hello. But her nutrition is good يا ماما. Her nutrition is good.
ايه؟ عايزه ده؟
Hypermobility is not very.
Yeah, she's like